চেক হ্যালো দেখা তো এবার চেক হ্যালো হ্যালো চেক চেক হ্যালো 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 চেক চেক হ্যালো 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 চেক চেক টেস্ট হ্যালো হ্যালো এই অডিও তখন দেখলে যে তুমি নিয়েছো কোনটা বলো তো আমি সেটাই মানে মেন আউট আমাদেরই কি বল চেক হ্যালো হ্যালো চেক চেক হ্যালো 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 চেক চেক টেস্ট হ্যালো হ্যালো এতগুলো এক্সেল লাগানো আছে চেক হ্যালো হ্যালো চেক চেক হ্যালো 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 তোমার তো ওখানে নিচ্ছে তো চেক হ্যালো 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 চেক, হ্যালো হ্যালো, হ্যাঁ চেক হ্যালো হ্যালো
না, হ্যালো, হ্যালো, এটা তো আমার এখানে।
হ্যালো 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 চেক হ্যালো 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 হ্যালো
দেখি এবার বন্ধ কর। এইবার মনে হয় হবে, দেখি।
কথা বলো তোমার ল্যাপটপে নিচ্ছে না
হ্যালো, কিন্তু ল্যাপটপে ডাইরেক্ট নিয়ে নিচ্ছি। হ্যালো,
দাদা তুমি যে ডাইরেক্ট দিয়েছো আমার ওখানে কিন্তু অডিও বন্ধ হয়ে গেছে আউটপুট অডিও
ডাইরেক্ট দিতেই
হ্যাঁ আউটপুট দিয়ে আর অডিও বেরোচ্ছে মনিটারে বেরোচ্ছে না চেক হ্যালো
এই তো
মনিটারে বেরোচ্ছে ওই স্পিকারগুলো বন্ধ হয়ে গেছে
এটা দিতেই
হ্যাঁ
তাহলে কেবলের প্রবলেম তাহলে।
কেন তুমি খোলো 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 আর নয়েজও চলে এসছে একটা
হ্যালো হ্যালো,
চেক এই দেখবে বাইরের সাউন্ড হয়ে
জানি না কোথ দিয়ে নয়েজ আসছে, কি বলবো আমি বুঝতে পারছি।
চেক হ্যালো 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 চেক হ্যালো চেক হ্যালো হ্যালো চেক চেক টেস্ট হ্যালো 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 ওই বিচ্ছিরি নয়েজটা চেক হ্যালো 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 চেক কর্ডের ডিস্টার্ব নেই কর্ডের ডিস্টার্ব এলে আসতোই না চেক হ্যালো 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 চেক চেক টেস্ট হ্যালো হ্যালো চেক চেক হ্যালো হ্যালো চেক হ্যালো হ্যালো চেক
হ্যালো হ্যালো
আরে ওটা হালকা চেক হ্যালো 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 চেক কিন্তু অডিও কোথায় চেক হ্যালো হ্যালো চেক
No, no, you come here because today I am not able to do it. You come here and do it. Okay. Yeah, yeah.
চেক হ্যালো 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 না এখন ওই বিটকেল আওয়াজটা তো নেই হালকা যদি একটা হালকা ওটা কোনো অসুবিধা নেই কিন্তু ওই চেক হ্যালো হ্যালো চেক চেক টেস্ট হ্যালো হ্যালো তাহলে গান চালিয়ে দিচ্ছি দাঁড়ো গান চালিয়ে দিলে গানটা তো কি
सरस्वती देवीभ्यो नमः। ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः। ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः। सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः ॐ ह्रीं ऐं क्लीं सरस्वती देवीभ्यो नमः
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणाम्बरदण्डमण्डितकरा या श्वेतपद्मासना।
जो विद्या की देवी भगवती सरस्वती कुंद के फूल, चंद्रमा, हिमराशि और मोती के हार की तरह धवल वर्ण की है और जो श्वेत वस्त्र धारण करती है, जिनके हाथ में वीणा दंड शोभायमान है, जिन्होंने श्वेत कमलों पर आसन ग्रहण किया है,
या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
तथा ब्रह्मा, विष्णु एवं शंकर आदि देवताओं द्वारा जो सदा पूजित हैं, वही संपूर्ण जड़ता और अज्ञान को दूर कर देने वाली माँ सरस्वती हमारी रक्षा करें। वाणी तथा विद्या की अधिष्ठात्री देवी माँ सरस्वती हिंदू धर्म की प्रमुख देवियों में से एक हैं। इनकी उपासना करने से मूर्ख भी विद्वान बन सकता है। माघ शुक्ल पंचमी को इनकी पूजा की परिपाटी चली आ रही है। सृष्टि के प्रारंभिक काल में भगवान विष्णु की आज्ञा से ब्रह्मा ने जीवों, खासतौर पर मनुष्य योनि की रचना की। अपनी सर्जना से वे संतुष्ट नहीं थे। उन्हें लगता था कि कुछ कमी रह गई है, जिसके कारण चारों ओर मौन छाया रहता है। विष्णु से अनुमति लेकर ब्रह्मा ने अपने कमंडल से जल छिड़का। पृथ्वी पर जल कण बिखरते ही उसमें कंपन होने लगा।
ॐ जय सरस्वती माता मैया, जय सरस्वती माता सद्गुण वैभवशालिनी, सद्गुण वैभवशालिनी त्रिभुवन विख्याता। ॐ जय सरस्वती माता।
ॐ जय सरस्वती माता
Hello. Good morning, everybody present in this hall, and those who are outside are requested to come inside. We are going to start our first program of the conference, Dr. Barin Rai Chaudhary Consultant Award. We are going to start Dr. Barin Rai Chaudhary Consultant Award. May I request our three judges, Dr. Dipankar Mukherjee, Dr. Pakira, and Dr. Ramanuj Sinha, to come onto the dais and take their chair, please. Soikat, ready? May I request Dr. Soikat Shomaddar, our first presenter of the consultant, Dr. Barin Rai Chaudhary Consultant Award, to come to the dais, please. Your time is 8 minutes plus 2 minutes. Questions will be asked by our judges. শঙ্কর দা আসুক তারপর
টাইমারটা উপরে
এসিটা চলবে না তো চলছে
টাইমার কিন্তু তোমাকে দেখে নিতে হবে এখানে টাইমার
আচ্ছা এটাকে এটা ঠিক আছে
Our next contestant will be Dr. Shubhadeep Karanjai. He is requested to keep himself ready.
টাইমার প্রেজেন্টার ভিউ লিখেছি না
अच्छा ये শুভদীপ সৈকত আচ্ছা স্কোর মানে তোমার যদি সিঙ্গেল কেস হয় হ্যাঁ তাহলে আমাকে মেনশন করতে হবে তাই তো অপারেটিভস মানে এটা কি মানে আমি এটা হ্যাঁ প্রত্যেকের জন্য তো আলাদা আলাদা শিট দিয়েছে দেখছি হুম না 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 দিস ইজ আমাকে মেনটেন করতে হবে পুরোটাই আর কি
এটা ওর পাতা
হ্যাঁ ওর কথা ইটস ভেরি টাফ
আপনাকে স্কোরে যে যত স্কোর টিক মারবেন ওটাতে
হ্যাঁ মানলাম কিন্তু
জিরো টিক মারবেন কি
না টোটাল কত
টোটাল ফাইনাল কাউন্ট হবে এই যে এখানে টোটাল স্টাডি হলে স্কোর দেওয়া আছে
ও আইদার জিরো ম্যাক্সিমাম
ও যদি একটা সিঙ্গেল কেস প্রেজেন্ট করে জিরো হবে
ইয়েস
তারপরে অ্যাড করে এখানে আসবে
আচ্ছা আচ্ছা এগুলো তাই ভেরি পুয়ার আচ্ছা
খালি টিক মেরে কোন নেচার টিক মারলেই
সেটা বুঝতে মানে হ্যাঁ সকাল
এখানে টিক মারবেন যদি সিঙ্গেল প্রেজেন্ট কেস প্রেজেন্ট হয়
চশমা দে এবার চশমা দে
মানে
হ্যাঁ
আমি যেমন
সানগ্লাসটা নিয়ে এসেছি চশমাটা ফেলে
এটা তো ফেশিয়াল করছি হ্যাঁ এরিকম অফ ল্যাটার এইটা পার্সপেক্টিভ অ্যানালিটিক্যাল স্টাডি ঠিক আছে
ওটা এই এভিডেন্স
ডিসকাশন তো করবার কিছু নেই কনসালটেন্ট আবার হ্যাঁ ডিসকাশন খুব একটা
এইভাবে চলবে আর কি।
ডিসকাশন হ্যাঁ
সব যোগ করে এখানে টোটাল আসবে
ও
টোটাল 50 আছে
সেটা পরে হবে
ডিসকাশন 2 মিনিটের মধ্যে ডিসকাশন
ঠিক আছে ঠিক আছে
8 মিনিটও বলবে আর 2 মিনিটে কোয়েশ্চেন
না কনসালটেন্ট শোনো না সিনিয়র কনসালটেন্ট অ্যাওয়ার্ডে ডিসকাশনের সেরকম কিছু নেই ইট ইজ এ প্রেজেন্টেশন মানে ইট ইজ এক্সপেক্টেড দ্যাট হ্যাঁ দে নো এভরিথিং হ্যাঁ ইট ইজ এ সিনিয়র কনসালটেন্ট হ্যাঁ হেন্স দি চান্স অফ হ্যাঁ তুমি সিএসএফ রেনোরিয়াতে ফার্স্ট ম্যানেজমেন্ট কি করবে করবে ও করবে দিস ইজ নট রিকোয়ার্ড your topic সৈকত
স্যার শ্যাল আই স্টার্ট
huh? না they will give
তুমি টাইমার স্টার্ট হচ্ছে হ্যাঁ দাঁড়া এক মিনিট তুমি বললে হাত তোলো তাহলে ও স্টার্ট করবে
টাইম মেনটেন করছো তো
Good morning, respected judges and delegates. It was around 10 months back that a colleague of ours called us to inform that his father has developed Bell's palsy and he has put him on oral steroids. But to his dismay, the palsy has progressed. There has been headache, nasal stuffiness, blurring of vision, and deranged glycemic status. We later diagnosed him with COVID-associated mucormycosis with rhino-orbitocerebral presentation and was admitted in an Apex Care Center for mucormycosis in West Bengal. In the present scenario, COVID-associated mucormycosis is a well-known disease entity. Symptoms of nasal, orbital, and intracranial involvement is common, but facial nerve palsy is a far less known presentation. With this prelude, I, Dr. Soikat Samadar, shall present before you facial nerve palsy, still an enigma for the otolaryngologist. My seniors and my mentors have always said, always before a research, you should have a research question and a hypothesis in your mind. The research question over here is, can facial nerve palsy be a presenting feature of rhino-orbitocerebral mucormycosis? We hypothesized that mucor is an angioinvasive pathogen and can invade the vasa nervosum of the facial nerve, leading to neural hypoxia and inflammatory edema. This edematous nerve in a non-yielding bony canal leads to further neural damage. It can even cause perineural invasion. The inflammatory neuritis of the SARS-CoV-2 is a well-known entity. So we conducted a descriptive observational study between May 2021 to January 2022 in our Apex Mucor Care Hub of West Bengal, with the aim to find the incidence of facial nerve palsy in ROCM, to document the disease evolution, and to predict the route of involvement. Mucor is defined as a laboratory identification of mucorales by PCR or histopathology or culture in a clinically diagnosed case of invasive mucormycosis. COVID-associated mucormycosis are those cases who have positive SARS-CoV-2 report or a rapid antigen report within a preceding 60 days period. Nasal, orbital, or intracranial presentations are stamped as rhino-orbitocerebral mucormycosis. New onset facial nerve palsy in these patients became the population in our study. Contrary to the patients that you have been seeing as of now, this patient is a patient of mucormycosis with orbital and nasal involvement with facial asymmetry, but this is not a case of true facial nerve palsy. So these kind of patients were excluded from our study population. Those patients who consented for the study went through history taking, regular clinical examination, classification of the facial nerve palsy was done. They were followed up radiologically and via nasal endoscopy and was managed as per institutional protocol. As Lord has said, let there be light, and we shall discuss our findings. We shall bring our findings to light and discuss them in the view of the available literature. The facial nerve palsy in our cases were 11 amongst 149 cases of ROCM, so the incidence turns out to be 7.3 per 100 cases of ROCM. The age range of the study population were between 25 to 68 years with a mean age of 50.18 years. We included 2 index studies who had similar subset of patients published by Rajeshri Mane et al. And Rupa Mehta et al. In whom the mean age was 50.75 and 48 years respectively. Diabetes is an important comorbidity associated with mucormycosis, with Indian perspective of 78% prevalence in mucor patients. In the index studies that we referred to has a diabetes prevalence of 100%. In our study, we had a prevalence of 54.54% of the patients. Our research team was meticulous in documenting the day of onset of facial palsy. And we were astounded to find that in 4 cases, facial palsy was the most common initial presentation. Average duration of onset of facial palsy was 5.63 days with a standard deviation of 4.43 days. We categorized facial nerve palsy based on its laterality and found all the patients who have a unilateral onset facial palsy. And this can be explained by the unilateral onset of the invasive mucor disease. Lower motor neuron palsy dominated the group, and House-Brackman scale score of 5 was the most common score. The initial symptom in this patient in our study population was facial nerve palsy, followed by headache. Other common initial presentations were cheek numbness, eye congestion, diplopia, diminished vision. In a multicentric study conducted across India by Sen M et al., over 2826 rhino-orbitocerebral mucormycosis patients showed headache, nasal discharge, proptosis, and diplopia to be the most common initial presentations. Radiological findings in this subset of patients shows paranasal sinus involvement is almost all of the patients. There was followed by orbital involvement. No patient had a temporal bone involvement. The disease spread was documented and it was classified clinico-radiologically into the superior route and the inferior route. The superior route of disease spread occurs via posterior, lateral, and superior to the paranasal sinuses to involve the pterygopalatine fossa, infratemporal fossa, the temporal bone, the floor of the sphenoid, the greater wing of the sphenoid, the infraorbital and the supraorbital fissure, the orbit, and then into the intracranial component. The facial nerve can be involved within the temporal bone or outside the stylomastoid foramen, or the disease can spread retrogradely from the median nerve to the greater superficial petrosal nerve to the facial nerve trunk. If we consider the inferior route, the disease can spread across the palate and the alveolus to involve the soft tissue and skin of the cheek, and then involve the terminal branches of the facial nerve to spread retrogradely. In our study, superior route was the most common route of spread. To summarize, I would say the incidence of facial nerve palsy in ROCM is quite high. Fourth and the fifth decade of life are the most vulnerable age group. Diabetes is the mostly commonly related comorbidity in these patients. Facial nerve palsy can occur within week. It can be even the first symptom, so it can mimic a case of Bell's palsy. Upper motor neuron facial nerve involvement is an ominous sign. And in our follow-up case, all the patients with the upper motor neuron lesion died during the follow-up. Surgical debridement and antifungals remains the mainstay of treatment and not the steroids. So I would conclude by saying, be mucor-minded. Be cautious while dealing with unilateral facial nerve palsy in the post-COVID era. Elicit the past history of COVID-19, examine for associated finding, do a nasal endoscopy, and judiciously use steroid only after excluding the underlying grave pathologies. As it is rightly said, every cloud has a silver lining, and knowledge is the silver lining to this cloud. Thank you.
Shoykot, hello.
Yes, sir.
It's a nice presentation.
Thank you, sir.
And you have not mentioned any treatment. Definitely you have done treatment protocol.
Yes, sir. The treatment was done.
For us, can you mention the surgical treatment and medical treatment? 3 points.
Right, sir. Sir, all the patients were followed as per institutional protocol. They were, after diagnosis of invasive mucor, we started them on liposomal amphotericin B. Surgical debridement was done as soon as possible, but we did not have to decompress any of the facial nerves because the temporal bone was not involved. And after surgical decompression, we have found that in around 60% of the patients, there was improvement in facial nerve palsy.
After that, any drug you want to add for long-term follow-up?
Sir, for long-term follow-up, we have been seeing the following the patient radiologically and biochemically. When the CRP reduced and radiologically there was no evidence of disease recurrence, we put the patient on oral therapy with posaconazole.
What is your radiological findings? How it helps?
Sir, radiologically, we did the gold standard investigation, that is the magnetic resonance imaging with contrast in T1 weighted in T1 image with gadolinium contrast. We found that there was a black turbinate sign or necrotic tissues were not taking up the contrast, so there was black regions in those area. And in the facial nerve, if the facial nerve was involved, there was increased uptake in the facial nerve region. There was hyperintensity. And this is the most important finding that we were seeing. Thank you, sir.
Okay, thank you, Dr. Samadar. It is a very nice presentation. Thank you.
Thank you, sir.
Thank you, Dr. Shoykat Samadar. Now, may I request Professor Utpal Jana to hand over the certificate of participation to Dr. Shoykat. Now, may I call Dr. Shubhodip Koranjai. Is he present here? Shubhodip?
Shoykot.
Shubhodip nahi. May I request Dr. Olokendu Basu to start his presentation.
চশমাটা আছে নাকি তাড়াহুড়ো এত দিয়েছি এই মর্গের কাছে মর্গের সামনে মর্গের কিন্তু লক করে এসো হ্যাঁ
হ্যালো
ঠিক আছে
থার্ড যে অলোকেন্দু বসু না না ওর বলছি
হ্যাঁ বলো
জন্য ঠিক করে দেবো হ্যাঁ সেকেন্ডটা চলে আসছে
আমি না এখন মিটিংয়ের মধ্যে আছি হ্যাঁ আমি তো 2 ঘন্টা পরে ফোন করব আমি তো বারবার করে দিচ্ছি 2 ঘন্টা পরে ফোন করব এটা তো কিছু লাগবে না ওটা
Hello.
ডাবলই দেখি দুটো স্ক্রিন দেখবেন নাকি
না না একটাই
একটা স্ক্রিন দেখবেন ঠিক পয়েন্টার স্টার্ট টাইমার অন করো স্টার্ট
Good morning, judges and delegates. Today I am going to present a paper on audiometric evaluation of hearing loss in diabetes mellitus patient. Introduction. Diabetes mellitus is a progressive metabolic disorder characterized by abnormality in glucose utilization owing to absolute or relative insulin deficiency. Its prevalence is 51 million in India, and microvascular complication includes neuropathy, retinopathy, and nephropathy. It involves the auditory neuropathy, and it is a shining example of central neuropathy. And SNHL is involved in this case, and a relationship between SNHL and diabetes mellitus was first reported by Jordan in 1857. Now the histopathological changes. Macroangiopathic changes with patch depositions occur here, hemorrhages in the endolymph and the perilymph, decrease in the number of ciliated cells, atrophy of the spiral ganglion, demyelination of the 8th cranial nerve occurs here. Now the aims and objective of my study was to profile the audiological finding in diabetic patients by assessing the degree of hearing loss and presence or absence of otoacoustic emission, and to correlate the parameters such as age, gender, glycemic status, and duration of diabetes mellitus. It was a prospective comparative study, and the 60 diabetic patients were included as cases, and 60 age and sex matched non-diabetic patients were the control group. The audiological assessment was done by pure tone audiometry, impedance audiometry, and otoacoustic emission. Now, the inclusion criteria. The patient diagnosed with diabetes attending the ENT OPD and the medical wards, both the sexes, age group of 25 to 70 years. And the patients with history of ear discharge, trauma, radiotherapy, ototoxic drugs, measles, mumps, chickenpox were excluded from my study, and also the patients with conductive or mixed type of audiometric curves were excluded from my study. And among the control group, the inclusion criteria were age and sex matched non-diabetic patients attending the ENT OPD and medical wards, both the sexes, and age and group of 25 to 70 years. And exclusion criteria include the history of ear discharge, trauma, radiotherapy, ototoxic drugs, noise exposure, and ear surgery, and viral infections. Now coming to the results. This chart depicts the age distribution among the patients, and we can see that most of the patients were among the age group of 56 to 70 years among both the groups. This depicts the sex distribution among the patient, and in our study, we can see that among the control group, male were predominant in our study. This is the chart showing the comparison between the SNHL in both the groups, and we can see 60% of the patients had SNHL among the case group, and 31.67% of the patients had SNHL among the control group. This is the age-wide distribution of sensorineural hearing loss in both the groups, and we can see most of the patients were among the age group of 56 to 70 years with SNHL. This is the relation of hearing loss in relation to sex distribution, and among the case group, 62% of female had SNHL, and in the control group, 36% of male had SNHL. This chart depicts the correlation between the hearing impairment with duration of diabetes, and we can see 29 patients had SNHL with duration of diabetes less than 7 years, and 83.87% of patients had SNHL with duration of diabetes greater than 7 years. This is the relation of fasting blood sugar level with the level of hearing loss, and we can see the patients with fasting blood sugar level less than 150, one patient had mild hearing loss, and 2 patients had moderate to severe hearing loss. And with FBS 150 to 200, 15 had mild hearing loss, and 3 had moderate hearing loss. And with fasting blood sugar level greater than 200, 8 had mild hearing loss, and 6 had moderate hearing loss. Now this is the relation of postprandial blood sugar level with the level of hearing loss, and we can see with the PPBS level less than 200, one had mild SNHL, and with PPBS 200 to 250, 14 had mild hearing loss, 2 had moderate hearing loss. Now, this is the correlation of sensorineural hearing loss with controlled or uncontrolled diabetes, and we can see 19 patients with HbA1c less than 7.5% had SNHL, and 21 patients with HbA1c less than 7.5% had SNHL in the non-affected cases. Now, this is the chart showing the otoacoustic emission finding in the diabetes mellitus patient, and we can see otoacoustic emission was bilaterally present in 25 patients and unilaterally absent in 8 cases and bilaterally absent in 27 cases. Now, coming to the discussion. Various studies showed that the correlation between the diabetes and the decreasing hearing acuity are present at higher frequency. Our study supports the association of sensorineural hearing loss with diabetes with an incidence of 61.66%, which was as compared to the 31.66% among the non-diabetics, similar to the study done by Dalton et al., Shakuta et al., and Bhaskar et al. HbA1c indicates the control of blood sugar level in the past 3 months, and out of 20 uncontrolled diabetes mellitus patients, 17 had SNHL, while out of 40 patients with good glycemic control, only 19 had SNHL. This was in accordance with Sumathi et al. Otoacoustic emission, which indicates the functioning of outer hair cells, it were found to be affected in 55% of the diabetics, and this result was similar to the studies done by Simonelli et al. And Agarwal et al. Now, coming to the conclusion. Patients with diabetes mellitus showed high frequency, bilateral, mild to moderate SNHL as compared to the controls of similar age. The prevalence of SNHL increases with age. Hearing was affected in both the sexes equally. Fasting blood sugar level, postprandial blood sugar level, and HbA1c level had significant correlation with the level of hearing loss. Diabetic subjects showed a higher rate of compromised OAE than the healthy individuals. These were the limitations of my study. Now, the recommendation. The screening for diabetics should be done after age of 30 years. Healthcare providers should incorporate audiological evaluation in long-term follow-up of diabetic patients. Routine screening for hearing loss may also help to improve the quality of life by early intervention. These were some of my references. Thank you.
Thank you, Dr. Bose, for your very nice presentation.
Welcome, sir.
So, 2 points. Did you find any definite audiological audiometric pattern in patients of sensory hearing loss with diabetes?
So, not definite, but there was high frequency hearing loss in the audiometric curve in all the patients, most of the patients.
Yeah, it should have been one of your findings in your presentation. And second is, did you calculate the significance of this difference, percentage difference between the two?
Yes, sir. There was a statistically significant difference between the two populations, and we have calculated by the chi-square test and every statistical test.
But you have not published any p-value for that.
I have not mentioned in this, yes, sir.
Okay, thank you.
Welcome.
Any advantage of OE over pure tone audiometry in your study?
So, there was basically not an advantage, but we have done OE with by seeing the affection of the outer hair cells, because in OE the outer hair cells are affected, and in diabetes mellitus that outer hair cells affection is more. So, we have done OE to see the affection of that thing.
What was the cochlea is infected?
Cochlea.
Part of cochlea.
So, in the cochlea the modulus is involved, and the internal auditory artery and the spiral stridovascular part of the cochlea are involved in these cases. We have studied.
Thank you, Dr. Alokendu. May I request Dr. Utpal Jana to hand over the certificate of participation to Dr. Alokendu Bose. May I now request Dr. Ambali Sahadevan to come up to the dais for her presentation, please. Dr. Dipanjan Chakravarti should be ready for the next presentation. Ambali Sahadevan, number 4 এ আছে এই যে এটা
এটা তো অলোকেন্দু তো হ্যাঁ তো ইয়েটা শুভদীপ ও আসেনি আচ্ছা আচ্ছা আচ্ছা
বিলি সহদেবন তাই তো
ফরওয়ার্ড ব্যাক दोनों में बोले ये बीच में पकड़ा नीचे पकड़ा नीचे ठीक है बी कंफर्टेबल
Respected faculty and delegates, I am here to present a case series on cochlear implantation in children with syndromic association. The term syndrome implies that in addition to the hearing loss, there are distinctive clinical features associated. The objective of the study is to analyze the anomalies in temporal bone anatomy found on radiological evaluation, the surgical challenges encountered, and the audiological benefit acquired in syndromic children. So coming to the statistics, over the 6-year period of the study in a tertiary care referral center in eastern part of India, we encountered 6 syndromic children of the 94 total cochlear implant patients. It's a retrospective observational case series. And the syndromes encountered were Waardenburg syndrome, congenital rubella syndrome, Susac syndrome, and Chart syndrome. This girl was referred to our hospital at the age of 3 years as a case of Waardenburg syndrome with bilateral profound sensory neural hearing loss for the consideration of cochlear implantation. Waardenburg syndrome is an autosomal dominant syndrome which is characterized by heterochromia iridis, hyperplasia of the eyebrows, and white forelock of hairs. And the characteristic association of the Waardenburg syndrome is that the hearing loss will be associated with depigmentation in the skin and hair. This is because there is mutation in the PAX3 gene which causes which affects the formation of the development of the melanocytes, which helps in pigmentation and also helps in the development of the inner ear. This is a routine evaluation we are doing in our hospital. Audiological evaluation again confirmed bilateral profound sensorineural hearing loss. And on radiological evaluation, there was enlarged vestibular aqueduct. Vestibular aqueduct is thought to be enlarged when it is more than 1.5 millimeter in diameter, or if it's enlarged more than the posterior vestibular canal. So we were expecting a surgical challenge of removal in this case, as even though the cases of enlarged aqueduct will not result in perilimb pressure, we encountered a perilimb pressure in this patient, and we could easily tackle it when placing a tissue. The cochlear implant used in this case was advanced bionics Iris 90 advantage, and complete insertion version was achieved. Intra-neural response telemetry showed satisfactory response, and the child is on follow-up for audio-verbal therapy. The child's parents are highly motivated, and they are doing a meticulous audio-verbal therapy. And the child is benefiting in terms of audiometry, speech perception, and speech intelligibility. So coming to the next case, it was a diagnosed case of Chart syndrome. Chart syndrome consists of coloboma, heart disease, coronal atresia, growth anomalies, genital anomalies like hypogonadism, and ear anomalies including hearing loss. The case we got had bilateral profound sensorineural hearing loss, but on radiological evaluation, to our surprise, there was the absence of cochlear nerve. So nothing we could done, we had to abandon the procedure. So next was a case of Susac syndrome. It is not a diagnosed case of Susac syndrome, it's a suspicious case of Susac syndrome. It's a 6-year-old girl
with bilateral severe to profound sensorineural hearing loss. We got the suspicion of Susac syndrome because of the MRI finding of snowball lesions in corpus callosum. Susac syndrome is a rare syndrome in which it's a triad of branched retinal artery occlusion, encephalopathy, and deafness. But luckily, the radiological imaging was within normal limits. Cochlear nerve was present. And the cochlear implant used is advanced bionics high-risk 90K advantage, and we could achieve the complete insertion. And neural response telemetry showed good response, and the patient is on follow-up. Next is a case of congenital rubella syndrome. It was a 2-year, 11-month-old boy who had a maternal infection of rubella during the first trimester. And the patient had congenital heart disease. It was an operated case of patent ductus arteriosus, and there was also congenital cataract. Audiological evaluation showed bilateral profound sensorineural hearing loss, and there was rotated cochlea. So accessibility to round window was compromised. Usually in our center, we do direct round window insertion, but in this case, we did cochleostomy and complete insertion was achieved. Neural response telemetry showed good response, and we are awaiting the follow-up. And this is a case of another congenital rubella syndrome. Here, the mother was not knowing that she had a rubella infection, but on probing, we could get a history of fever during the first trimester, which was not treated in hospital. And the patient had, the child had PDA with cataract, and consultation was done. And radiological evaluation showed bilateral severe to profound sensorineural hearing loss. Radiologically, it was normal, so there was no surgical challenges in this case. Full insertion was attained, and the child is on follow-up. So to summarize, the individual outcome may vary, but majority of the patients with syndromic association benefit with cochlear implantation. Proper workup and careful treatment planning should be done. All the parents should be counseled regarding the realistic expectation before implantation. And good audiological outcomes will definitely improve the quality of life of children with syndromic association. Thank you.
Thank you for your presentation.
Thank you, sir.
Acha, mention 1 or 2 more syndromes where you will face difficulties. 1 or 2 syndromes which is not in your paper.
Sir, Usher syndrome, Pendred syndrome.
Have you not seen Mitchell or Mondenis syndrome in your study?
Mondenis is a dysplasia, sir. It's normally 1.5 turns of cochlea will be there. It is a dysplasia. It's not a syndrome.
It is not in your study?
No, sir.
Okay. During insertion,
Yes, sir.
what are the 3 structures
Yes, sir.
you will take precaution not to injure by your cochlea, array, insertion array?
The electrode should be
Yes, electrode array.
electrode array.
What are the 3 structure you will take precaution not to injure by your electrode array? It is a multi-channel.
Yes, sir.
It is not a single.
It's a multi-channel.
Multi-channel. So
Multi-channel electrode.
what are the 3 structure you will take precaution?
3 structure.
You will take precaution. You have done cochleostomy, you have inserted.
Yes, sir.
But
Yes.
3 structure you have to take precaution. Have you heard the name of basilar membrane?
Yes, sir. Basilar membrane should be taken care of.
Yes.
Basilar membrane.
Spiral ganglion?
Yes, sir. Spiral ganglion. That's a spiral ganglion, basal membrane. Yes, sir.
Okay.
How MRI helps? How MRI helps?
So MRI helps in identifying the cochlear bundle. The internal acoustic meatus may form a nerve bundle. Will identify the nerve bundle and will definitely have to visualize the presence of cochlear nerve. Even though the procedure is success, if the patient is not having a good cochlear nerve, the surgery is not a success.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, Dr. Ambali. May I request Professor Utpal Jana to hand over certificate of participation to Dr. Ambali Sahadevan, please. Thank you. May I now request Dr. Shubhadeep Koranjai to come up to the dais and start his presentation, please.
শুভদীপ করঞ্জাকে তুমি জিজ্ঞেস করো শুভদীপ করঞ্জাও তুমি জিজ্ঞেস করবে আমি পারবো না অ্যাসিড বেস ব্যালেন্স কী হবে না
Good morning, respected teachers and members of the audience. The topic of my presentation is perioperative acid-base disturbances in major head neck oncosurgeries with reconstruction. It is a retrospective case series. Electrolyte imbalances and acid-base disorders are considered deleterious for the postoperative recovery of our patients. The aim of the study was to evaluate the prevalence and time course of electrolyte and acid-base disturbances after major head neck oncosurgeries with flap reconstruction. This was a single-centered retrospective observational study. We chose 40 patients and the duration of study was 1 year, that is from January 2021 through December 2021. The inclusion criteria of a study was age between 18 to 70 years with ASA grade 1 or 2, patients requiring intra-arterial pressure monitoring, and those requiring post-op ICU admission. We excluded patients who underwent emergency surgeries or who required re-exploration of the neck or the primary within postoperative day 3. And also the patients with inadequate data were excluded from the study. Patient characteristics like age, gender, the ASS status, BMI, comorbidities, and duration of surgery were collected. The ABG analysis was done pre-incision, immediate post-op, and on POD 1. Also, the serum electrolytes were also measured pre-incision, immediate post-op, and on POD 1. Intra-op fluid and blood loss were also measured. Standard base excess below -2 milliequivalent per liter, that is the base deficit below 2 milliequivalent per liter, was used as the main indicator of metabolic acidosis. The primary objective of this study was to measure the incidence of metabolic acidosis and secondarily to analyze the trends of pH, anion gap, electrolytes, and relevant anions at each measured point. For statistical analysis, for comparison between the time points, data were tested for a normal distribution and a paired student t-test was performed, and clinical outcome was compared using ICU and hospital length of stay and mortality. We analyzed total 52 records during the last 1 year during the study period. 3 were excluded due to re-exploration, 9 were excluded for inadequate data. So total 40 records were selected. As we can see, the age the mean age was about 50.92 with a standard deviation of 9.66. The BMI was 28.3, 3.91 standard deviation. 23 patients had ASA grade 1 and 17 patients had ASA grade 2. The primary diagnosis of the patients, we had 10 patients of CA tongue and 30 patients of CA buccal mucosa. The reconstruction, the PMMC flap reconstruction was done in 10 patients. Free anterolateral thigh flap was done in 19 patients, and free radial artery forearm was done in 11 patients. The duration of surgery, the mean duration of surgery was 467.25 minutes with a standard deviation of 30.29, and the time of anesthesia was just a bit higher, obviously. The blood loss was like 612 plus minus 197 ml. The critical care length of stay was median 3 days with a range of 1 to 4 days. And the blood transfusion amount was 426.25 liter plus minus 142.78 ml. The results show that pre-incision, 15 patients had a base deficit of 2 milliequivalents per liter. At the end of surgery, that number went up to 65, and on post-op day 1, it came down to 12.5, means almost to the pre-incision level. Similarly, the pH, we see that the mean pH was pre-incision, it was normal 7.4, but at the end of surgery, there was an acidosis 7.34, which most of it was corrected on POD 1. All the other parameters are more or less normal, except the lactate, which we see is shooting up to 3.58 plus minus 2.55 at the end of surgery, but it also gets corrected on POD 1. On the regression analysis, the summary of the regression analysis shows that the duration of pre-op fasting and history of diabetes on oral drugs appears to significantly affect the incidence of pre-op metabolic acidosis. The type and amount of fluid replacement along with intra-op ventilation parameters, they also appear to significantly affect the incidence of post-op metabolic acidosis, but most importantly, surgery length was not significantly correlated with the incidence of acidosis. In conclusion, incidence of metabolic acidosis significantly increases the ICU stay as well as hospital stay. It depends upon multiple factors which can be modified, like pre-op fasting, intra-fluid management, and comorbidities like diabetes. But high-powered RCTs should be planned in future to further diagnose the factors and ways to prevent acid-base disturbances pre and post-surgery. As ENT surgeons or as head neck surgeons, what are our roles? To revisit the concept of overnight fasting. Like, we find it very convenient to make the patient fast overnight, but this concept should be critically re-evaluated, because the overnight fasting increases the rate of metabolic acidosis even pre-incision or post-op. Now it is recommended that the fasting should be like 4 hours, maximum 4 hours solid fasting and 2 hours for liquid fasting. Improved nutritional status of the patient before surgery should be looked at. Strict control of diabetes and other comorbidities preoperatively, and avoidance of drugs like metformin or linezolid, which contribute to metabolic acidosis, should be avoided. Thank you.
So, thank you, Dr. Karanjai, for your good paper. So, what was your direct correlation between the postoperative metabolic acidosis with your flap survival? Or
no, sir. There is no significant correlation.
But
the duration of hospital stay and basically the post-op morbidity increases.
Yeah, please continue.
Yes, sir.
Yeah. Oh, there is no correlation.
There was no correlation between flap survival and acidosis.
Then what was your main aim of your
to correct the acidosis pre-operatively, so that the length of hospital stay, the post-op morbidity decreases.
That's okay, but as you have mentioned in your topic, that you have done the study on maxillofacial oncosurgeries with flap reconstruction.
Yes.
But
that is due to the
But your inference is basically is true for any surgery,
no,
particularly
sir,
any prolonged surgery, isn't it?
Yes, but just as the surgery prolongs, there is the fluid loss and all this ventilation and the fluid correction, they get jeopardized. That's why this thing gets significant in this type of surgery.
Yeah, but
blood loss is a factor.
Is not related to flap survival.
No, blood loss is a factor basically.
Blood loss is a factor. Okay, thank you.
Thank you, Dr. Shubhadeep Karanjai. May I request Professor Utpal Jana to hand over the certificate of participation to Dr. Shubhadeep. And now may I request Dr. Shubhadeep Shodhar to come to the rise. Thank you.
Madam.
আচ্ছা এটা কিন্তু জ্বলছে না।
Good morning, respected judges and my seniors. My topic is use of modified microdissection needle in supraauricular approach in management of preauricular sinus, a novel technique. As we all know that preauricular sinus occurs due to defective fusion of hillocks of His, which develops as a mesenchymal proliferation at 4th week of gestation. This entity was first described by Husinger and Virchow in 1864. 25 to 50% occur bilaterally. It courses with many ramifications up to the level of temporalish fascia. There are two classifications. Congdon's classification classified it into 7 types, and Choi et al. Divided it into 2 types depending on the extended tragal line. Asymptomatic cases do not require any treatment. However, the cases which have more than one episode of infection, they require surgical management as a definitive one after subsidence of infection. There are 3 modalities of surgical management, out of which radical wide local excision or the supraauricular approach is seen to be having the lowest recurrence rate cited in different literatures. These are the techniques of inside out technique and supraauricular approach technique. The principle of supraauricular approach relies on the theory that the fistula is almost always included into the subcutaneous tissue between the temporalis fascia and the perichondrium of the helical cartilage. Now, for many craniofacial-maxillary incisions, we prefer to use Colorado tip because of less dissipation of energy resulting in smaller zone of necrosis, less damage to the adjacent tissue and faster healing. But it is single use and it costs around $55. So, for a resource constrained country like us, we came up with an idea of modified microdissection needle which requires a 22 gauge needle to be separated from its hub, a monopolar diathermy, a 8 French infant feeding tube to use as an insulator and a connector between these two. This is how it looks like. So with this I come to the aims and objectives of my study, which is to show the efficacy of the supraauricular approach in management of the preauricular sinus and to show that the MMDN, or that is the modified microdissection needle, can cater as an effective alternative to microdissection needle in preauricular surgery. It is a prospective observational study conducted in indoor inpatient department over the PAS patients between January 21 to September 21 over 7 patients and 9 samples being operated. Patients with PAS who gave informed consents are included in the study, and syndromic patients, patients with active infection and patients who refused consent are being excluded from our study. After selecting the patients, we performed supraauricular approach using MMDN. Then we followed up the patients for up to 3 months to see the surgical site infection and recurrence. Now the results and analysis. The patient's age ranges from 3 to 49, with most being in between 11 to 30 years. There is no such sex predilection in my study. 5 cases were bilateral, rest were 5 cases were unilateral, rest were bilateral, and all of the bilateral cases had positive familial history. 6 were anterior helicine type and rest were crural type according to Congdon's classification. 6 were classical type and 3 were variant type according to Choi et al. This is the anterior helicine type on the left side. This is the crural type on the right side. 5 patients had associated scar. So we can see a large scar with a preauricular sinus. This is a preauricular sinus without any scar, and 1 case had a postural fistula along with a crural preauricular pit. 2 patients had associated cysts. These are the arrow points towards the pit and the cysts along with it. 1 patient has surgical site infection where the healing, we led the patient to heal by secondary intention, and the pictures of the successive stages of healing in respect to time frame is being shown, and the complete healing occurred in 2 months. Now the procedure. how we approached. We approached all the patients with MMDN, starting from the incision to the dissection and remove along with the excision of the portion of cartilage. In most of the cases, we tried to identify the superficial temporal artery, and then we did a closure. Depending upon the condition of the wound, we chose Vicryl or Ethylon 30. There are a few more pics where we removed the specimen along with the piece of cartilage. Whole procedure was bloodless in most of the instances, as it was conducted with the MMDA needle. And this was the post-op follow-up. This is immediate post-op. This is for post-op after 3 months. This is pre-op picture. This is again a pre-op picture with a post-op after 2 months. There is a comparable sex ratio in my study between the genders. Mean age was 21.8 years. 5 patients had unilateral PAs, rest were bilateral PAs. 6 PAs was anterior helicine type or classical type, and rest were crural type or variant type. 5 PAs had associated scar, 1 PAs had associated postural fistula, 2 PAs had associated cyst. Average time taken is 20 minutes, and SSI was noted in 1 case. Reason being the improper perioperative glycemic control as well as a trivial trauma in the region of in the operated region. No recurrence noted, which reflects the findings by Lam et al. Similar low recurrence rate is also shown by Prasad et al. And MMDN catered as a good alternative to microdissection needle. There are 2 papers which I used for creating my microdissection needle. Although it has its own advantages, it has some distinct disadvantages like less control because the distance from the shaft and the tip increases. Stabilization of assembly needs to be done properly before starting the surgery, and higher chance of needle stick injury. To conclude, supraauricular approach is a simpler, easy to perform with reduced recurrence and appreciable cosmesis. MMDN can be a good alternative for a developing country like us. Strict glycemic control in perioperative period is necessary, proper wound healing and faster recovery. These are my references, and thank you for patient hearing.
Shubhadeep, so it is basically a diathermy.
Yes, sir. It's basically diathermy where we use a stainless steel and make it a pointed tip to make less tissue damage in the surrounding area, less heat dissipation.
But what precaution you have taken when you come close to the cartilage?
I have reduced the wattage to 10 to 15 and I have tried to separate the skin from the cartilage before making the incision.
Do you think it is superior to your conventional technique?
Huh? Sir?
You think it is conventional, it is much more superior in comparison to conventional
the
technique?
surgery was bloodless and it was easy to perform as compared to monopolar diathermy. There is less smoke production as the contact of tissue and the...
In terms of recurrence?
In terms of recurrence, sir, I have performed this study for only a duration of 9 months and followed up the patients up to 3 months. So sometimes patient might recur after that. So it's very difficult to comment on now. Over a long period of time, as we continue to do this procedure and taking the conventional procedure as a control, we can comment on. Now it's not the time to comment on that.
What is the post-operative result?
Post-operative result, till now there was no recurrence and one patient has surgical site infection. That was due to improper post-op glycemic control.
How much it is cost effective?
Sir, it only needed monopolar diathermy and a 8 French infant feeding tube or a suction cannula and 22 gauge needle, and this acts as an insulator, and I think it's pretty cost effective.
Single use.
Huh?
Single use.
This tip gets charred a bit, so we have to remove it, but we can use this diathermy again.
Your idea is very good.
Thank you,
No,
sir.
no, thank you.
Okay, thank you.
Thank you, Dr. Shubhadeep. Now, may I request Professor Jana to hand over the certificate to Dr. Shubhadeep, please. Our next participant is Dr. Saurabh Gupta.
A very good morning to respected chairpersons on the dais and respected seniors and dear colleagues. Today I am going to talk about handling the middle turbinate in FES. Now, since time immemorial, we have always strived for perfection. And as we can see, and we are still continuously striving for perfection. Now, the middle turbinate is a key structure in the nasal cavity. Normal size and the bulk of the middle turbinate determines the drainage pathways of all the paranasal sinuses. So even if it is diseased, it causes a lot of problems even after the surgery. Now, the main goal of FES is maintenance of sufficient drainage and ventilation at the level of middle meatus. The middle turbinate bulk and the position is directly affecting the drainage of all the groups of paranasal sinuses even after the surgery. So, the normal middle turbinate has to be intervened to have a successful outcome of surgery. Now, the middle turbinate can jeopardize the outcomes of the result in many ways. So, we need to deal with it accordingly. Now, inadequate management of the middle turbinate has resulted in complications. So, the surgeon may have done a beautiful surgery, but the middle turbinate has played a spoilsport and caused synechia and lateralization, which hampers and leads to early recurrence. As we can see in this video, the synechia and between the middle turbinate and the lateral wall has impacted the surgery outcome and lead to early recurrence. I have taken this study with an objective to determine the ideal management approach of the middle turbinate and to optimize the surgical outcomes in FES and to assess the outcomes of middle turbinate interventions techniques. Now, it is a prospective comparative study I have done at a tertiary center hospital, and a total of 50 middle turbinates of 44 patients were studied. The surgery and the middle turbinate intervention was done after failure of the maximal medical therapy. Now, this is the basic design of my study, and in which the pre-op assessment was done, endoscopy score was taken, and the patients were divided in 4 groups. The first group, patient underwent decompression of the concha bullosa. Second group had a lateral laminectomy done. And the third group, we had the wedge resection of the anterior inferior part of the middle turbinate. And the last group underwent suture medialization after the surgery. And after the surgery, post-op assessment was done with the POSE scoring at 6 weeks, 3 months, and 6 months of interval. Now, it's a single blinded study. The operating surgeon was a senior surgeon who on the table decided what intervention the patient will undergo after studying the CT scans and after seeing the middle turbinate after decongestion. And we excluded patients below 18 years, those requiring revision surgery, and patients also requiring septoplasty along with FES. My study duration was 6 months, and routine pre-operative, post-operative protocol was followed. And perioperative sinus endoscopy scores were used to assess the nasal cavities. Now, I have taken this scoring because this subjective SNOT 22 questionnaire and validated Lund Kennedy endoscopy score does not include the middle terminate into its consideration. So another validated endoscopy scoring system I took, because it takes the middle terminate into the account and we can judge accordingly. The total score is 20 maximum, and this is how it. Now, mean and standard deviation was calculated, and the chi-square test was used to compare the significance. Now, 10 patients underwent decompression, while 13 had lateral laminectomy done, 16 patients had wedge resection done, and 11 had a suture medialization. The concha bullosa decompression was done with incising the mucosa and removing the bone part and reposing the mucosa back. Now, lateral laminectomy was done using a BP blade or fess scissors, and in which the lateral part of the middle terminate was removed, and along with the mucosa and the bone. And anterior wedge resection, the anterior part of the middle terminate, anterior-inferior part, was removed using fess scissors. So as we can see, it's a bulky bone and without SL, so we reduce the bulk in the axial plane. And suture medialization was done at vicryl was taken after the surgery and passed through the middle terminate and septum, and suture was taken out, and a knot was placed on the same side of the nasal cavity. So we see where it's a little bit technical and demanding procedure. So the results, the POSE scores pre-operatively were comparable in all the groups. But as we see, at 6 weeks, there's nothing much to comparison in all the groups, which the similar POSE score was seen. But at 3 months, we see the difference. As we can see, the decompression had a lower POSE score, while the wedge resection had a significantly higher POSE score. But at the end of 6 months, all the scores become similar, again, with no significant difference between all the groups. Endoscopic findings at 3 months, we see the maximum crusting was seen in the wedge resection group, and synechia also was seen in wedge resection maximally. But at the end of 6 months, crusting and synechia were comparable on the groups. So at 3 months, the wedge resection predisposes to more crusting, and requires a lot of endoscopic monitoring. And we had a better endoscopic score for lateral laminectomy and suture medialization. So as per my study, partial resection does not seem to provide any extra benefit. Comparing previous studies done, in 1992, 673 patients were taken with LASA and studied, and complications of FES were seen. So nearly a 43% had middle terminate synechia. While in 2012, Bune et al. Had done a prospective non-randomized cohort in which wedge resection decision was taken intra-op, and the endoscopy scores were worse than the other group. And suture medialization really does not affect the olfaction as demonstrated by Hegazi in 2015. So the middle terminate bulk and position is critical, and we have to manage the normal middle terminate.
Cervical spondylosis. Those patients, we cannot do this Epley's maneuver.
And also in acute vertigo?
In acute vertigo, yes, sir. But sometimes in acute vertigo, we have to perform the Epley's maneuver because it is difficult to perform. But if we can perform it, it will definitely give them relief.
And another thing, how long, whether you will take help from medical management, and if you use drugs, how long you will ask the patient to continue with the...
Normally, we give, sir, beta-histine hydrochloride for 3 weeks.
3 weeks.
If it is adult patient, 24 milligram TDS for 3 weeks, normally. No, 24 milligram TDS for 3 weeks, normally, adult patient.
You can give maximum.
Maximum, that is the dose, sir.
That is the maximum dose.
That is the maximum dose. For BPPV patients, sir. For BPPV.
So thank you very much.
Yeah, thank you very much.
So we have come to the end of the session.
Hey, hey.
Thank you, Dr. Anirban Ghosh. May I request Dr. Chandan Ghoshal to hand over memento and certificate to Dr. Anirban Ghosh, please. May I now request Dr. Utpal Jana to hand over memento and certificate to Dr. Chandan Ghoshal. May I request Dr. Jana to hand over memento and certificate to Dr. P.B. Roy. May I now request Dr. Jana to hand over memento and certificate to Professor Dr. Bibhash Odhigari, please. Next, our next session is Dr. A.M. Shaha Research Paper Award. Speaker is Dr. Ushrin Bose. Topic, JGB2 mutation. Is it a predictive factor for outcome of cochlear implantation? Chairperson for the session are Dr. Debashish Shanal and Dr. M.A. Rashid. May I ask Dr. Rashid and Dr. Shanal to take the chair in the dais, please. Dr. Odhikari wants to say some few words, please.
Thanks to our association. Today my mind is full of joy. I can see my all beloved senior teachers in the front row of the audience. I can see our junior brothers, my colleagues, my students. Thanks to association, yes, we can fight against all odds and dreadful COVID. Yes, we can win. Thank you.
আমায় বলে দাও। Good morning. Now we are going for Dr. A.M. Shaha Research Award. Actually, 6 candidates were there and there was a tough competition. It is an original paper and there were 3 professor judges and they decided ultimately, and every paper was very good as I gathered from the judges, and the first who stood first, because you know one person will be first, and I call Ushrin Basu on the dais. A big claps for her. Ushrin, come here. Ushrin, just come here and tell your college what you are doing now. Just a moment.
Good morning to all the delegates present here. I am Dr. Ushrin Bose from Ramakrishna Mission Seva Pratishthan, Vivekananda Institute of Medical Sciences. I'm working as an assistant professor there. I've finished my surgical residency in Ramakrishna Mission for around 4.5 years. I have done my MBBS from Karnataka, and I have finished my PG from MKCG Medical College at Kolkata, Orissa, and following which I did my residency here.
Thank you.
Thank you.
Now, please stand here. Come. Come into center. This is the medal. It's my proud privilege. Boriye dilam mala. Now she will start.
Please start.
Good morning, respected chairpersons at the dais, seniors, and all the dignitaries present today. At the outset, I would like to thank AOIWB to select my research work and allow me to present in this August forum today. I, Dr. Yushirin Bose, am going to present on GJB2 mutation. Is it a predictive factor for outcome of cochlear implantation? The World Health Organization defines hearing disability as complete or partial hearing loss. 1 to 6 out of every 1,000 new presenting with bilateral profound hearing loss. Though the hearing disability is a global burden, but WHO predicts that by the end of the year 2050, in the developing countries, especially in the Southeast Asian countries, around 267 million children and adults will be presenting with hearing impairment in some or the other form. This is quite high in the Southeast Asian countries. The statistics of world disability in hearing is staggering. Over 5% of the world population requires some form of hearing rehabilitation in some form or the other, out of which children constitute nearly 35%. In India, the condition is worse. 63 million people suffer from severe to profound hearing disability, with 22 million children among these. Around 3 to 4 children per 1,000 live birth present with sensorineural hearing loss. As minor as these may sound as numbers to you, but the magnitude of the problem is much deeper and higher. It comes with an extra baggage of social stigma, low self-confidence, and a definite setback in the society. So sensorineural hearing loss can be genetic or non-genetic. Majority of the hearing loss comprises of the genetic part of the hearing loss, which is most commonly or most often the autosomal recessive and the non-syndromic hearing loss. Around 400 syndromes, genetic syndromes, have been associated with hearing loss, like the Stickler syndrome, the Pendred syndrome, the Treacher-Collins syndrome, and the Peary-Roba syndrome. However, these syndromic children, they contribute less number of patients to the sensorineural hearing loss. And they come with an extra baggage of multi-system involvement, multi-system manifestations. So non-genetic sensorineural hearing loss is a partial or a total hearing loss that is not associated with any other systemic presentation. Genetically, more than 70 loci for non-syndromic hearing loss have been identified, and the main genes out of these 70 loci of concern are the GJB2 gene and the GJB6 gene. These genes encode for gap junction proteins connexin 26 and connexin 30. Out of these connexin 26 genes, more than 100 different mutations have been identified. The most common mutations are the 35 del G and 167 del T mutations. The second most common mutation in the connexin 30 gene is the 342 kb deletion gene. This is a very familiar picture of the organ of Corti, which comprises of the inner hair cells and the outer hair cells. GJB2 gene is very concentrated in the outer hair cells, which are important for the amplification of the sound through the basilar membrane. So GJB2 genes is present in the interdental cells, the supporting cells, and the cells of the stria vascularis. With this background, we took up this study with the aims to study the patterns of genetic mutation in non-syndromic hearing loss, to compare the hearing and speech outcome of cochlear implantation surgery in mutation positive vis-a-vis mutation negative subgroups, and last but not the least, to compare the outcome of cochlear implant surgery in children with mutation of different varieties. It was a prospective study done during the duration between 2014 to 2021 in Ramakrishna Mission Seva Pratishthan, Vivekananda Institute of Medical Sciences, Kolkata, with a sample size of 77 children. Informed consent for participation in the study, consent for genetic study and genetic counseling, and for surgical intervention post the genetic study was taken from all the parents of the children enrolled in this study. Out of the 3,287 ENT outpatient attendees during this period, 140 children complained of sensorineural hearing impairment. Out of these, 77 had non-syndromic hearing loss. The syndromic children were excluded from this study. 30 of them had genetic mutations, and 17 underwent cochlear implantation. Side by side, we had a control group of 17 patients who underwent cochlear implantation and did not have any genetic mutation. So we included prelingual children between the age of 1 year and 5 years, a non-syndromic congenitally deaf child, adults, postlingual deafness, syndromic deafness, children with low intelligent quotient or a development quotient less than 49, and any child who was exposed to orthodoxic drug exposure was excluded from the study. A detailed history of the antenatal, natal, and the postnatal events occurring in the mother, a family history of any consanguineous marriage, any early onset of hearing loss in the family was taken in detail. Temporal bone imaging to evaluate the anatomy and morphology of cochlea, to evaluate the cochlear and the facial nerves, and to test the integrity of bilateral cochlear vestibular system was done in detail. A detailed evaluation of hearing with ASSR and an aided audiogram in order to decide the side of the surgery was done for all patients. This is the setting of the Department of Genetics at Ramakrishna Mission Seva Pratishthan, and where the DNA studies were performed for the connexin 26 and 30 loci by sequencing the 3 ml of blood sample from each child to polymerase chain reaction. These polymerase chain reaction gave out some products which were then analyzed by using the Providentia Stewart restriction enzyme or the PST1 enzyme. The outcome measures, especially the auditory outcome measures, were rated by the revised category of auditory performance score, which is a globally validated questionnaire from Canada comprising of 12 questions which test the auditory perception of the child in question in comparison to the environmental situation. This rating is done collectively in a team by the team of surgeons, the audiologist, and both the parents. The speech outcome measures were again rated by the speech intelligibility rating score, which comprised of 5 questions. This is also a globally validated questionnaire, and it tests the connected speech and the intelligibility of the speech of the subject in question in everyday basis. This is also done in a team by the surgeons, the audiologist, as well as both the parents should be present during the rating score. All the data, all the patients underwent auditory verbal therapy. The revised CAP scores and the SIR scores were calculated at 2 weeks, 3 months, 1 year, and 2 years. A PAIR-T test and a chi-square test was used for the statistical evaluation by the SPSS 2.0 software. When we compared our results, we observed the mutation pattern in 167 del T mutations. We have found that there were 16% of the cases which had homozygous mutation, 13% had a heterozygous mutation, and 55 children had wild variety of the mutation. Almost all cases, that is 100% of the cases, had a negative for 37 del G mutation in the population. When we compared the auditory outcome after 2 years of cochlear implantation among the varieties of 167 del T mutation, we observed that the revised CAP score of the homozygous variety went up from 3.5 to 7.5. And the revised CAP score of in the pre-implantation time for the heterozygous variety went up from 3.2 to 10.8, which clearly states that the heterozygous variety of the mutation performed better with cochlear implantation. This value was statistically significant. On comparing the speech outcome between the homozygous and the heterozygous variety after 2 years, we noticed that the heterozygous variety had a superior outcome with a SIR score of 5 when compared with an SIR score of 4 in the homozygous variety. This value was also statistically significant. The next limb of our study was to compare the outcome in mutation positive and mutation negative children. So we've observed that the revised CAP score and the SIR scores were way higher, about 11 and 5 respectively, in case of the mutation positive children. This was again a statistically significant data with a p-value of 0.004. With these encouraging results, we now look at the world literature. Batisoko in 2009 conducted a study with 41 children, out of which 80 individuals presented with mutation of GJB2 and GJB6 gene. It was a Brazilian population where 36 del G was the commonest mutation. However, they could not quantify the homozygous and the heterozygous variety of mutation. In our study, 167 del T was the commonest. We did not find any 35 del G cases, and we could quantify the homozygous and heterozygous variety of the 167 del T mutation, which was new in our study. In 2008, Davis et al. And Illinois, they conducted a study in 55 patients where they published data of mutations of del 36G and 167 del T to be the most common. They also followed up the patients for 5 years. And they found that there was a superior outcome in 167 del T mutation subgroup patients. This was quite similar with our study. Epsteiner et al. In 2008, they predicted that the cochlear implantation performance is much better in children with mutation in the spiral ganglion lesion. As we also know that the spiral ganglion are rich in GJB2 genes, thus this fact reiterates that the children with GJB2 gene mutation show an excellent outcome with cochlear implantation backed up by evidence in medicine, and this reiterates the importance of including genetic testing in our setup of hearing loss patients. Another Indian study published in 2015 by Venkatesh et al., they published the need for genetic counseling. The unique feature of our study here is comparison of long-term cochlear implantation outcome in between the heterozygous and the homozygous variety of mutations of 167 del T. And to the best of our knowledge, there is no other study which has been published in the eastern zone, though the hearing disability rates are quite high in this part of the country. Thus, we conclude by our study that there is a definite association of mutation with hearing loss. 167 del T is the commonest mutation. No 36 del G was found in this population, despite there have been literature which have suggested the presence of 36 del G in other ethnic groups and other countries. Post-cochlear implantation outcome was better with the heterozygous variety of 167 del T mutation and also better in the positive mutation positive subgroups. Looking into the future, we strongly recommend the inclusion of genetic testing in the test batteries of the hearing loss patients, as genetic counseling and testing will help in early detection, and also maybe inclusion of amniocentesis to look for any sort of anomaly for the future pregnancy, as India is not a country where there is any sort of population control. So the amniotic fluid analysis of the second child will help in early detection and early retreat. And let's all work in a team, not only in the field of genetics, but also as a surgical team for the cochlear implantation surgeries to create the future. And Because at the end of the day, we want a happy patient and thus a happy doctor. This is a video of a patient, one of our patients who has undergone cochlear implantation and has developed very good speech. Thank you. I sincerely thank my mentors, my Department of Genetics in our institution, and all the other team members who have helped me in this research. Thank you.
Thank you. Thank you. Excellent. We are very proud. We are very proud that our juniors are doing excellent job like this, and this is a new horizon that Ustina has walked. Congratulations, and I think we must give again a big clap for her. No question. If you have anything, you can discuss with her later on.
Thank you, sir.
Thank you, Dr. Hussain. May I request Dr. A.M. Shah to hand over memento, certificate and a cash award of rupees 5,000 to Dr. Hussain Basu. Sir, much करना है. May I request Dr. Shamul Ghosh to hand over memento to Dr. Devashish Sannal, please. Our next session is Dr. S.P. Ghosh Memorial State Oration. Today's topic is coblation in ENT. Speaker is Dr. Jayannath Gurtu. And the chairperson for the session are Dr. A.M. Shah, Dr. Probir Basu, and Dr. Sumit Kumar Basu.
Jayannath Gurtu, JN Gurtu. And a puro lecture time. Pointer আছে Wait. On করো না পয়েন্টারটা অন করো অন আছে ঠিক আছে না স্যার মাইক অন আছে Good morning everybody. Good morning to
Dr. Guttu, may I introduce a little bit of for whom you are speaking. It is the state oration in the name of a late Dr. Sharoda Prasanna Ghosh, popularly known as Dr. S.P. Ghosh. He was a teacher of many of us. Professor Sharoda Prasanna Ghosh was born as the 8th child of Mahaprasad Ghosh in Dhaka. He was all along the interest in the science, and ultimately he joined in the Calcutta Medical College from the Dhaka, came and joined in the medical college in the medical profession because mostly of his death of his father, and he thought the father was not properly treated, and that was his inspiration. With these few words, I pay my homage to late Dr. Sharoda Prasanna Ghosh, our teacher, popularly known as S.P. Ghosh. And for this state oration, Dr. Jane Guttu will deliver his revelation in the memory of Dr. Sharoda Prasanna Ghosh. Dr. Guttu, please. Yes, sir. Please. Please, Dr. Guttu.
Good morning to chairpersons and all the delegates of 49th Annual Conference of and Vocal Nodule. Here you can see a simple skygram of the neck shows how much is the tongue which is enlarged. I generally reduce the posterior third of the tongue only in the middle, center part, about 2.5 to 3 centimeter in the medial part, so which is devoid of blood vessels. Now, what is coagulation assisted upper wear procedure? It's a multi-stage treatment where we can choose any step to treat the patient depending on the clinical need. For example, most of my cases in this series I have 90% cases were involved, and I have to do either a septoplasty or the turbinate reduction or reduction of the concha bullosa, then reduction of uvula, soft palate, and laterally the anterior and posterior pillars. So CAUP is a generalized term used because you can combine these procedures in various ways which are needed. This video clip shows the difference between the coagulation and the coagulation works at 40 to 65 degrees centigrade, and the other procedures or diathermies, they work at 300 to 400 degrees centigrade, which causes a lot of damage to the neighboring tissue. Here you can see I have been doing inferior turbinate reduction with the tonsillar wand. As you know, the inferior turbinate is very vascular, but in spite of that, you hardly see any bleeding. And if there is any oozing left after the resection, I coagulate with the same instrument. So here you can see smoothly the reduction is being done from proximal end to the distal end. After the resection, now you can see I am coagulating the margins so that no oozing is left behind. And post-operatively I feel dry and patient is happy that there is no bleeding at all. The other way to reduce the inferior minutes is to use the channeling channels which can be inserted from proximal and distal and some mucosally. Depending on the size of the turbinate, maybe you can make 1 or 2 channels, but try not to overlap each other. This is very famous procedure in Dr. Magni's clinic. Selected patients are given local anesthesia. Thereafter, it comes to the surgeon. Assistant is holding the tongue depressor, and the surgeon is giving a cut with the coagulator wand, and you can see that this is also bloodless. And the cut is made at the between the base of the uvula and the upper pole of the tonsil at 45-degree angle, and it goes up to the just below the junction of the hard and soft palate. It doesn't go beyond that because otherwise the nasal regurgitation will take place. The same procedure is repeated on the other side. If there is any oozing, this can also be used as a coagulator, as we have seen. After doing the same procedure on the other side, the snoring wand is passed through the uvula and coagulated. Once you have coagulated, then you can resect. So there is no loss of blood or minimal loss of blood. Here you can see after coagulation, removal of the part of the uvula. Here also you will see that the stump of uvula is left behind because it heals by fibrosis and it comes in alignment with the soft palate. After this procedure, the same snoring wand is passed at right angle upwards at 2-3 levels, so and pass the current for 15 to 20 seconds. This is enough to make the soft palate stiff, so that after the healing and recovery, the soft palate doesn't fall on the posterior part of the nasopharynx. This is very important step which I used to forget in the beginning and suffered in some of the cases. The same procedure is repeated on the other side. The snoring wand is passed upwards in the soft palate at 2-3 levels, and current is passed for 15 to 20 seconds. Once this procedure is complete, then I pass the same wand in the anterior and posterior pillars of the tonsil, which will reduce the lateral bulge. So it gives complete reduction in the oropharynx and gives lot of space for person to breathe. The same wand is passed, see, not hurting the mucosa. As you pass, you can see the bubbles coming out for 15 to 20 seconds, and you will see visibly reduction of the bulged pillars. This is another common procedure which I have been using under general anesthesia. And the tonsillar wand is I use mostly. Again, the incision is given at the level of the junction of the base of the uvula, between the base of the uvula and the upper pole of the tonsil. And it is cut through and through up to the below the level of the hard palate to make a good space between the palate and the posterior wall. The same procedure is repeated on the other side. And if there are any bleeders during the process or after, you can coagulate it instantly by changing the pedal. Again, after making the cuts on the soft palate, the uvula is reduced, leaving little bit of stump at the base, as you can see in this video clip. Stretch the uvula by holding it from the apex and then make the cut, clean cut. Once you have made the clean cut, the enlarged uvula is shortened, and again leaving the short stump for healing to take place, and the stump will come at the level of the soft palate. Here I would like to mention that anyway, I will go to the next slide. Tonsillotomy. I have hardly done 1 or 2 cases in last 18 years. But in case you find massive hypertrophy of the tonsil, you can even do the reduction with the same tonsillar wand. No need to do tonsillectomy. As you can see, this is also comparatively bloodless, and the tonsil is being reduced on first on right side or whichever side you prefer, and then on the other side. And you see how much space is created on the lateral part of the oropharynx. So this is tonsillotomy with UPPV. After tonsillotomy, you can repeat the same procedure which I have shown in the earlier video clipping. The same procedure is repeated on the other side. Thereafter, you can also do the uvulopalatoplasty. We'll go to the next video clip. Post-operative management. Observe the patient for a few hours with head end raised if done under local anesthesia. Cold drinks for 24 hours, maintain oral hygiene, avoid acidic liquids and strenuous physical activity for 2 weeks. Advantages: short anesthesia, bloodless surgery, minimal pain, fast recovery, hence less hospitalization, minimal damage to the surrounding healthy tissue, comparatively less complications, cool surgery, comparatively versatile, attractive to surgeon and patient as well. Results. In my series, the results are very encouraging. 60% of the cases show excellent results. 30% are satisfied. 10% may need second sitting at a later date, depending on the severity of the symptoms and response of the individual patient. Resolution of snoring is the success of the treatment and is determined by the bed partner on completion of the treatment. Patient is evaluated 4 to 6 weeks after coagulation. Here are some of the pictures of CAUP pre and post. This is also pre and this is post. Causes of surgical failure. Extreme obesity. Some of the patients are so obese that they find difficulty to sit up or move also. So I don't get good results with them. Lack of physical activity. Alcoholism. Mixed obstructive sleep apnea. That means peripheral obstruction plus the central sleep apnea. The central sleep apnea cannot be corrected with this procedure. The contraindications are velopharyngeal insufficiency, submucosal cleft palate. Those who are professional voice users, the procedure should be avoided, and also those patients who are suffering with swallowing disorder, and those who are chain smokers. Limiting factors: visible costs, invisible savings, resistance to change, lack of skill, learning period. Complications, some of them they get foreign body sensation in the throat, and if you do excessive removal of the soft palate, then nasal regurgitation and dysphagia. In summary, coblation or controlled ablation is the brainchild of Dr. Magni. After 20 years of research with other scientists at the Department of Otolaryngology, Voss Hospital, Norway, where I received the training, and I was among the first batch to receive the training at Voss. Earlier, snoring was considered to be a social stigma, but now it is known to be main cause of health hazard. 45% of or more cases of snoring occur in adults occasionally, and 25% are suffering from regular snoring. Coblator is a versatile tool in the hands of ENT surgeon and other specialty in surgery of adenoidectomy, tonsillectomy, uvulopalatoplasty, turbinate reduction, removal of hemangiomas, angiofibromas, vocal cord tumors, and other skull-based surgery. I used to promote initially for adenoidectomy because I find this is a wonderful tool for adenoid. Previously, adenoid used to be removed by adenoid curette, which used to leave certain tags there and post-operative bleeding. And also if somebody is vigorous, then they can damage the neighboring tissue. So I find adenoidectomy is best removed by these procedures. There are other procedures also available, I don't criticize that, but I find it is very helpful. After introduction of tonsillectomy wand in 1998, this technology has been used in more than 12 million procedures by ENT surgeons till date worldwide. Coblation wands are mainly of three types, and later on the laryngeal wand was included, and has a triple action of ablation, suction, and saline irrigation. And it works at 40 to 65 degree centigrade, as I mentioned earlier. That's why it does not damage the neighboring normal tissue, with less complication, faster healing, and it's non-painful. The cobbletter is mainly manufactured by Smith & Nephew, and of which they have made me a lifetime member. I thank you so much to all the delegates for patient hearing and giving me the opportunity. Thank you so much to association and secretary and all of them for giving me this opportunity to present before you the coblation in ENT surgery. Thank you so much. Thank you, ladies and gentlemen.
Thank you, Dr. Guttu, for your beautiful deliberation. And it is a oration, so there is no question. If anybody has anything to know, you can, during the lunch time, you can talk to Dr. Guttu. Thank you, Dr. Guttu, once again.
May I request Dr. A.M. Shah to hand over memento to Dr. Guttu, please. Oida. May I now request our past state president Manjula Bhattacharya to hand over memento to Dr. A.M. Shah, Dr. Prabir Basu and Dr. Sumit Basu. যাও। কাকে দিচ্ছি? এই তো। To Dr. Prabir Basu, please. Thank you all. Our next session is invited talk, Tympanoplasty Current Concept by Dr. Deepak Haldipur, who has come all the way from Bangalore to present his paper. Chairperson for this session are Dr. Debratan Nondi, Dr. Debashish Mukherjee and Dr. Orunavo Sengupta.
एक ही सेकंड में आप जो भी बोलेंगे
सर कौन सा है? डॉक्टर दीपक सर दिखा दीजिए सर कौन
है ना उसको दीपक हल्दीपुर सेकंड वन.
Dr. Deepak Haldipur, he is senior ENT consultant of Fortis Hospital, Vikram Hospital, Sagar Hospital, Cod Road Hospital, NR Hospital, Karin ENT Hospital, and Honorable ENT consultant of Indian Institute of Science. He is also our national past president of AOI.
ये नहीं आ रहा है ना उधर. Good afternoon, everybody. It's a great feeling to come back to Calcutta, Calcutta, especially after all the webinars which really made our brains into a web. It's so happy to be back here. I'm sure Dvaipayan will give me some muri in the evening along with the chai. And I get it's so nice to see Amitabha, so nice to see all the friends here. Calcutta is my second home, and today morning the cab fellow asked me, is it your first visit to Calcutta? I said, 21st. Precisely it is 21st. Let me start my talk. There is a purpose for which I chose this topic, because we are talking so much of skull base and so many other things, but these are surgeries which are done by a few people and they require a special setup. But at my age now, I think of social relevance, and I feel even now our country is a gold mine of these chronic ear cases, so many primary surgeries and so many revision surgeries. Even after last 40 years of intensive teaching in ear surgery, the number of graft failures that you see, the number of discharging cavities that you see, the number of patients having granular myringitis or mucosalized graft, recurrent ear infections, fungal infections, painful ears, difficult ears, and even now the sudden SN loss being not managed appropriately, means we need to revisit our otology, which is our basic thing. For a young postgraduate who finishes his course, otology is one of the affordable surgeries to practice. If you have a 2 lakh rupee microscope and a good decent Indian micromotor, couple of them, and a set of Indian microsurgical instruments with well-guided local anesthesia and the blocks, chronic ear surgery can still be an extremely cost-effective surgery in even the most rural areas. And if you can stop a discharging ear, you would have done a great service to most of the people in the country. I started my otology practice in 1990. I was trained for a brief while with Dr. Madevaya, precisely 42 days, but that was my basic surgery, which I learned first. From that point to today, a lot of concepts have changed, which is what I want to share with you. My other guru after Madhavaya, the man who shaped my destiny, Dr. Satish Jain, who taught me, I relearned almost all my surgeries after I came into contact with him. Without any hesitation, I call him a phenomenon in ENT. He always says, the first day I went into his OT accidentally, he had only 45 cases posted in the list. And out of which 42 were perforations. And he told me, though he was a prolific fest surgeon, he said otology is the bread and butter of any ENT surgeon. Dr. Madhavaya, my other guru, said, India is such a gold mine that if each one of you were supposed to do 3-year cases every day from now on, and if all patients were to get operated, for the next 20 years, you will have enough and more chronic ear cases to operate. Notwithstanding how many more children are going to be born in the next 20 years and how many more otology cases we'll have. And added to this is the effort of mediocre surgeons like me, which adds to more revisions and failures and more revisions, which add to the same number. And as I said earlier, otological surgery is one of the most affordable surgeries today if it is planned properly. Tympanoplasty, remember this is one graft in the entire body probably which has to lie on the air. Every other graft can lie on some tissue bed which is supported. Here your best taken temporalis graft or a tracheal pericordial graft or whatever has to lie across thin air and still have good vascularity, which is why the technique is very important. So the types, you know, onlay, which is practiced by few surgeons now. The interlay, which is an excellent technique which is practiced by Satish Jain and his followers, which can take care of the granular myringitis problem to a large extent, or the underlay technique which I have been practicing for the last 32 years, in which now I have modified and added a total annulus excision tympanoplasty for those patients in whom I feel these are likely to get into granular myringitis or mucosalization of the graft postoperatively. Materials, you have the temporalis fascia and the tracheal perichondrium and the conchal perichondrium also. This is a usual technique I follow. One point here is don't take the graft all the way below. This area is thick. Try to leave about 7 to 8 millimeters of the area and then take your incision to harvest the temporalis graft. Even in revision cases, you can go a little higher up and take the graft. This is a very good material. My friend Satish uses the microscope, goes down to the lowest layer and takes the actual fascia, which is a good technique. The important thing here is to have a dissective plane where your artery forceps should be seen through the graft. And then what happens, you won't be damaging any vein, creating a hematoma or an infection. Have a wide exposure. You can appreciate all the veins on the temporalis muscle there. The key is to have the correct plane. The other thing which you can easily take in revision cases also is the conchal perichondrium. You can see, expose the conchal cartilage posteriorly and then use a cotton to slowly rub it out, and you can take out a large piece of perichondrium on the concha. This is very easy to harvest and it can be a fairly large piece. When you do an ossiculoplasty in this, you can use different materials. You can use the cartilage from the floor, you can use of the canal, you can use the tracheal cartilage, you can use the conchal cartilage. There are surgeons who use biomaterials like Teflon, hydroxyapatite, and some people use bone. it is preferable not to use the auto-ossicle or the bone because there is a risk of ankylosis. If you have to use an auto-ossicle like a shaped incus or a shaped malleus, it would be a huge advantage if you have the intact chorda tympani, which can be an interface between the scutum and this bone. Otherwise, you have to ensure that your auto cartilage is tilted anteriorly and inferiorly so that the chances of this getting attached to the scutum are very less. But during the process of healing, the graft can shrink, and even with your best intentions, the bone can get stuck to the scutum. So it is any day preferable to use cartilage because the rejection rates are absolutely zero. And even if it comes in contact with the superior wall or the posterior wall or the scutum, the chance of ankylosis is zero. So the hearing results are very good. I'm just showing a type 4 tympanoplasty here using the floor cartilage being shaped. So I already spoke about the harvesting. The steps of tympanoplasty, the classical Madhavya technique. You have a curvilinear incision parallel to the annulus about 2 to 3 millimeters. This is in case of intact canal wall where I am fashioning the tympanoplasty using a circular knife. Now I use a 15 blade knife to place an incision along the 6 o'clock position and one more incision at the 11 o'clock or the 12 o'clock position. And then you raise the coroner's flap from medial to lateral towards the cartilage skin junction. The next step, of course, you can see after elevating the coroner's flap, you go ahead and freshen the edges of the perforation. I think yes. Freshening the edges of the perforation, you can just use the right angle needle or maybe you can use a sickle knife, basically to remove the sclerotic ring, excising it completely. It doesn't matter if the perforation becomes large and wider, see to it that the avascular part is removed completely. Now the scraping the undersurface of the graft with a Plester side knife. Now the perforation is enlarged and now we are scraping the undersurface, making it fresh. And now doing the canalplasty. So it's important to use either a conical burr or a small cutting burr and take away the bony humps in the canal because you should be able to see the entire annulus completely. This is a small release incision which you put at the 12 o'clock position so that when you place the retractor, the drum doesn't get lifted along with it. And then you extend this tympanomeatal incision now anteriorly So placing an anterior incision here so that the drum is attached only at between the 9 o'clock and 12 o'clock position only, and the entire thing is free. Now you gently elevate the whole thing at a 270-degree angle. In this case, I think the canal skin was very thin, so I've used this cotton ball to dissect. So basically, you elevate the entire flap. And then if you're planning an osteoplasty, especially if you're planning to use an auto incus, it's important to try and retain the chorda. And this really doesn't require an extreme skill. All that you need to know is the direction and the attachment. You can already see the IS joint there. You can see the malleus. And it's very important to dissect the malleus completely. I feel this step is very important in underlay technique. You need to really strip the entire malleus completely, denude it, so that you don't leave any mucosa in the undersurface. That is where you are likely to leave the mucosa there, and also anterior to the malleus. So here your dissection should be meticulous. Take your own sweet time. And here the concept has really changed now. Checking the pathways. Now mastoidectomy is actually not practiced much because you can establish patency by moving your probe in these 4 directions. 1, posterior to the incus and inferior to it. 1 is in the tympanic isthmus, anticus. You know, where you place the probe here, and you also, let me go back and again play that. चल रहा एक मिनट. So posterior to incus, and then you can see anterior to the incus, and then you again go above the tensor tympani attachment there and break the tensor fold there, and also go anterior to the malleus. So this way you are ensuring the auditor's patency. And then in case there is a matrix, in case of open cavity, you go ahead and do the cotton ball dissection to basically elevate the matrix. As you see here, all these are very short videos just representative of the technique to show you the importance of cotton ball dissection. You can also use a gel foam to use to dissect in the space in an intact ossicular chain. You can use the gel foam to remove the granulations from underneath the incus next to the stapes. And also you learn to remove this epithelium from difficult areas like sinus tympani, because 2 areas where you can leave squamous epithelium could be one in the sinus tympani where I'm handling now. You can look at the chorda and the area of sinus tympani there. So you need to elevate, especially when there's a small retraction. Use the 45-degree hook to dissect it completely free. This is one area where you can leave a residual retracted tympanic membrane. And one more is the supratubal recess. Snehashish, let me know when the chief guest comes, I'll cut the talk. Okay? Again, in the attic area, the same meticulous way of dissecting, either you use the cotton ball or 45 degrees hook. And you need to cut the tensor tympani tendon. There's a lot of emphasis now after Daniel Marcioni and Muaz Tarabishi have come in that we need to open up this pathway. This is the main cause for retractions or cholesteatomas. And the supratubal recess area is a very, you can see this canal for tensor tympani. You need to open up this area. The tensor fold will have a segment here and one component here. Both should be released. And then you graft. You are unlikely to get back a retraction or a cholesteatoma. So this area again, you have to elevate it very well. Expose the supratubal recess area. If there are any myelingosclerosis or tympanosclerosis, you just remove that patch. So this is one piece of the sclerosis which is there. Sorry, this video probably the clarity is not very good. But it's very important, if it is coming the way of your graft vascularity, that you take out the entire piece in one piece completely and have the remnant tympanic membrane left there. This way now we are able to see the eustachian tube area. Finally, we fill the middle ear with gel foam. If you are using the gel foam, because there are surgeons who don't use gel foam in the middle ear space, the surgeons who use it. If you are using the gel foam, it is very important that you keep the mucosa intact and abrasion free. The same gel foam which works wonderfully as a spacer can actually promote adhesions if you have created injury in the mucosa of the medial wall. It is very important in your technique that the medial wall mucosa is kept intact and abrasion free. And then the temporalis fascia, wet graft, dry graft. I have been using dry graft for the last 32 years. But just because you do one wrong thing for 32 years, it doesn't become right. If you are using a fresh graft, believe me, it's a better technique. I am 59. I started this in 1990. My mind and hands have become rigid, so I continue to use dry graft. But if you ask me today, I would recommend you people use wet graft. A fresh graft is always a better graft. I can't just say I've got excellent results, I've done thousands of cases, then we're not talking science. So I think you are all youngsters. I urge each one of you to use a wet graft. Because see, this is actually a self-defeating exercise. I make it dry, make a slit for malleus. Before putting it again, I'm putting it in ofloxacin dexamethasone, making it a little wet and putting it back again. What am I achieving? By putting the infrared lamp, roasting the tissue, and then again making it, wet and putting it. When you put a fresh graft, it integrates very well with the flaps. When you put a dry graft, it is actually working like a scaffold. It still works well. If you have freshened the edges well and placed it well, you will have a good closure of the perforation. But this point I want to emphasize, please move towards fresh grafts. You can see this is the size, and then I also make a slit for the malleus. You can make a slit after you place the graft as well with a 45-degree iris scissor, but I am used to making it even before, and I've continued that way. Placement of the graft, basically an underlay. So first you use your crocodile forceps and then you adjust it with the slit being brought around the malleus. If you have done a good canalplasty, you see in one smooth motion, your graft goes all the way there. You can see the slit which is made for the malleus, and now you slide the graft underneath the malleus. So that when the graft heals, it shrinks a little bit and it lifts up the malleus as well. Sculpting the cartilage. So basically, if you are doing a type 3 tympanoplasty, you make a notch for the stapes head. You can use this, or you can place it on the foot plate in those in patients in where there is the PISA sign. The stapes superstructure, if it is tilting towards the promontory, there you can even put the cartilage directly on the foot plate, wedge it between the facial nerve and this. Oh, sorry. I think this is the same cartilage, the type 3 tympanoplasty. You can see a small notch made there for the stapedius tendon, and I have sculpted and made a notch inferiorly. You also give it a slight slanting cut superiorly because the drum is always there at an angle. You can see the whole thing is sitting there now with the slit sitting correctly on the stapedius tendon. The height and the angle should be perfect. Wherever you feel a little bit of the attic wall needs to be removed, use a small diamond bar and take it out so that you get a good exposure of the attic area as well as the stapes superstructure. This is another concept. You saw me doing dry drilling. When I have a tympanometal flap very close to the burr, sometimes I do dry drilling where I drill and then irrigate, rather than irrigating, because the fluid can create a torque and sometimes the flap can get caught in your drill. You can use the conchal cartilage and reconstruct the attic as I have shown in this. You can see this should be the dimension where you should be able to see a small portion of here the stapes superstructure very clearly. Now the concept is changed after I saw Suri. It is better to have this cartilage with both sides mucopericardium intact rather than have it like this where it is denuded. And I showed you the graft placement in an intact canal wall. This is the graft placement in a canal wall down technique. You can see the muzzle flaps on both sides. Now you are placing the graft. Once you place the graft, you actually lift the graft and put these inferior and superiorly placed muzzle flaps going into the mastoid cavity and some free tissue. And this is how your graft sits in a tympanoplasty in an open cavity. And finally, the type 4 tympanoplasty, where only the foot plate is available. You do the same thing, take the floor cartilage, shape it, and put it back. The height is to be important, and then you put back the muzzle flaps. in the intact canal wall. Once you place the graft, you put back the old tympanic membrane or you reposition the flap. You can see the neotympanum is tucked well inside the intact, the old eardrum. You can see the perforation is completely covered nicely, and the graft is also lying on the canal. You make sure that your graft is positioned on the bony canal wall. This way you can ensure very good graft take-up rates or the closure of the perforation. I think it's 12:24. Snehashish, the guest has come. 7 minutes I have. No. Okay. This is my current passion. Total annular succession tympanoplasty. I've been talking about it for the last so many, maybe 2 to 3 years. In this underlay technique which I showed so far, the only problem was 3 to 5% of my patients would develop the localization of the graft and this granular meningitis. Every patient would come to me and I would show them that they graft neotympanum in the monitor. But patient had only one simple question. Sir, I came to you for ear discharge, itching ears and recurrent fungal infections. And even now, I am having the same problem. You are telling me the graft has taken up well, the audiogram is showing very good hearing, but my problems have remained. So I changed over to this technique in those patients in whom I see extensive granular meningitis. The whole idea is to convert it into a total perforation and then grafting. Here the emphasis is on exposing the annulus, but the most important thing is meticulously dissecting the malleus completely and then putting in a graft. So any perforation you change it to a total perforation. And stay next to the annulus and excise the entire tympanic membrane. We don't open the mastoid, just check the patency. You can see the way malleus is dissected with a cotton ball. A lot of time is taken so that ultimately the malleus is meticulously gnawed off whatever little mucous membrane which is there. Suri has designed an instrument called the Cobra, where the sickle knife with intense heat is bent to the shape of a cobra, which can be used to dissect the anterior part of the malleus. Because this area anterior to the malleus is where it is a little difficult to elevate the tympanic membrane without leaving even a bit of the mucous membrane or the tags. So here you take your time, be very meticulous. This is the essence of the total annular succession tympanoplasty, where your malleus should be totally free. This is the last video and I am ending my talk with this. 5 minutes, I think Dr. Bharti can get ready. I think you are next. This is just a video, I am talking through this. Another 5 minutes of video is there. You can come up, I think. We'll save another time. I thank AOI West Bengal for calling me year after year, listening to the nonsense that I talk and bearing with me. That is how the malleus should look at the end of your dissection, and then you make an open book, this thing by cutting the flap. And this is another instrument. These are the bent instruments. You can get it from Santosh Surgicals, where your plestus side gnime is bent at an angle of 45 degrees. It's also got these bent circular knives, so you can reach the annulus anteriorly and the anterior canal skin very comfortably and elevate it completely. I must have done about 70 cases of this in the last 2.5 years. And believe me, the results are amazing. I don't recommend you to do this in every case of a perforation, but wherever you have a hint that there's a fair bit of granular myelinitis, please do this. The take-up is very good. You have remarkably dry ears with no itching and no recurrent fungal infections. And it's a very simple technique to do actually. When you convert it into a total perforation, you have all the space to do your canalplasty and place the graft. But again, I would like to harp on the point that your dissection of the malleus should be very meticulous. This is where I am cutting the annulus now. First cutting the entire circle, making it an open book first. Once you do that and lift the drum, then you can see the annulus clearly, and then you can cut the annulus. You can see the annulus there. So whatever is interior to that, you can easily cut and remove the entire tympanic membrane, including the annulus, which contains some of the tubular glands. That is important. That line is important. You make the correct cut so that you are left with only the canal skin. And the healing is very rapid when you place the graft under it. I think I'll close it at this. Taking too much of time, let me give a chance to the other speaker. And maybe in the afternoon I can show the remaining 4 minutes or whatever, because we are running short of time. We are expecting the chief guest at any time. No, you can. स्नेहाशीष आ गया ओके 4 मिनट है वीडियो लास्ट और सामने इसके पहले इसके पहले हाँ ये आना चाहिए इसमें इधर आ जाओ हाँ उधर आ जाओ प्रेस करो उधर उधर प्ले करो है तो भी चलेगा, उधर तो ठीक आ रहा है ना। लास्ट वन, हाँ यही है। इधर ही प्ले करो, इधर ही प्ले किया था।
क्वेश्चन आंसर करते तो वो तो नहीं
उधर नहीं, इधर ही इसके ऊपर ही रख दो।
ये
आ रहा है
तो
नहीं आ रहा?
पूरे शाम
ठीक है, तो छोड़ दो, बाद में देखना है, कोई दिक्कत नहीं, आफ्टरनून में देखेंगे ना। निकाल दो बस। I think the last part, probably in the afternoon, we'll see that. I request Madam President, Dr. Bharti, to come and start the next talk.
Thank you, Dr. Huldipur, for your nice presentation. And if audience have any question, they can ask separately while leisure time. Thank you.
Thank you, Dr. Haldipur. May I request Dr. Debratan Nonde to hand over a certificate to Dr. Haldipur, sir, please. Sir. And now may I request Dr. Haldipur to stay back. I would request him to hand over the memento and certificate to the chairpersons, please. Sir. And now to Dr. Debashish Mukherjee. Exchange করে নেব, ওটাই দিয়ে দাও, একটা ভুল হচ্ছে, ঠিক আছে, ঠিক আছে, একটা ভুল হচ্ছে, ওটা রেখে দাও, ওটা সাইডে দিয়ে দাও, সাইডে দিয়ে দাও, এটাই সাইডে দিয়ে দাও, ফটো में उतना दिखेगा नहीं, এটা Now there is a small announcement. There is change of schedule in the program. Now we'll go for inauguration. We'll prepare the stage for inauguration, and Dr. Bharti's and Dr. Kaushal's lecture will be followed by the inauguration. দেবো,
আচ্ছা এই দেবদা, ওখানে তো হেড টেবিলে তো কোনো মাইক লাগবে না, সবাই তো যে যার এখানে এসে বলবে।
না রাখো রাখো, যদি বলে সুদীপ যদি বলে রাখো না।
ল্যাপটপ এখন লাগছে না।
Respected Dr. Sudipto Rai, ex-National President of IMA, MLA, Estimate Committee of Standing Committee of Health, and Estimate Committee of West Bengal University of Health Science, and Chairman of RKS. Dr. Shubhajit Banerjee, President AOI West Bengal Chapter, Dr. M.B. Bharti, President, National President of AOI, Dr. Kaushal Seth, Honorary Secretary of AOI, Dr. Satyabrat Banerjee, Inaugurator, Professor Ayan Kundu, HOD, Dr. Snehasis Burman, Organizing Secretary, Dr. Deepak Haldipur, past President AOI, Dr. Harshavardhan Bora, President-elect AOI West Bengal Chapter, Dr. Somen Bandyopadhyay, Dr. Doipayan Mukherjee, Dean of Student Affairs, RG Medical College, MSBP, RG Medical College, and all distinguished ENT Surgeons, ladies and gentlemen. It is an immense pleasure and privilege to address here and 29th Annual Otolaryngology of India West Bengal Chapter is held here at RG prestigious college, RG Medical College. I congratulate and welcome all delegates in RG Medical College on behalf of Principal RG Medical College. I have immense pleasure to congratulate you to good gesture and endeavor to arrange the beautiful annual conference of Otolaryngology of India at RG. Our organizing secretary, Dr. Snehasis Burman, I congratulate him to arrange everything, and Dr. Ayan Kundu and others, and they are continuously sensitized and preventive measure of deafness and cancer of ENT, head neck area. They are doing the beautiful job in RG Medical College and serving the patient community, and they are updated surgery, cochlear transplant, and also they are doing all endoscopic surgery here. I wish every success in their conference. I am grateful to all of you, and once again, thanks to you. Thank you, everyone.
Thank you, sir. May I now request Dr. Professor Doipayan Mukherjee, Honorary Treasurer and Trustee Board Member of our association, to deliver his message, please.
Good afternoon, respected dignitaries in the dais, my seniors, teachers, and colleagues. It's always a pleasure to be back in the physical mode of conference after almost 2 long years. AOI West Bengal is not just an association. This is a big family. So today is the opportunity of family get together once again. Here I like to thank and congratulate Dr. Sudipto Rai, the chairman of the Rugi Kollan Shomiti of RG Medical College, and the principal of the RG Medical College for giving all the support for this conference, which is led by Dr. Indonath Kundu and the ENT department of the RG Medical College. I also like to thank from bottom of my heart to the president of AOI, Dr. M.B. Bharti, past president of AOI, Dr. Deepak Haldipur, and honorary secretary of AOI, Dr. Kaushal Seth, for standing beside us in difficult time. I just want to mention another thing. This is 49th AOIWBCON. So next year will be the Golden Jubilee AOIWBCON. So I will request our All India leadership to extend all the support for this Golden Jubilee conference, and most likely this will be a mini All India conference for the next year. So I will like to invite all of them along with all the members of AOI for the next year conference. In last 2 years of corona pandemic, AOI West Bengal stood firmly with the members by doing extensive socio-economic activities, and I hope in future also this executive committee will continue same endeavor. Long live AOI West Bengal. Thank you.
Thank you, Dr. Doipayan. Now, may I take the privilege to welcome our distinguished guests and honorable guests of national body in a special and unique way. May I request Dr. M.B. Bharti, National President AOI, to take her seat in a special chair right there. Madam. Dr. Bharti M.B. is President of Association of Otolaryngologists of India. She is Senior Professor and former Head, Department of ENT, Head and Neck Services, JSS Medical College. She is B.C. Roy awardee and has received the Best Teacher Award. She has numerous publications in national and international journals. May we felicitate her with certificate, Mishti and gift. And may I request Dr. Shubhajit Banerjee, our immediate past president, AOI West Bengal, to felicitate her, please. May I request Dr. M.B. Bharti, our national president, to say a few words. Snehasis, please hand over the mic. Yeah. From there, ma'am.
No, I'll stand. Namaskar. Respected dignitaries and my brother Dr. Dwapan and my friends. It's indeed an honor and privilege to be here. Every time I come to Kolkata, like the warmth that's given by you people and the culture of yours has made me like feel that this is a second hometown for me. It's really, and from morning we have been seeing through all the proceedings, the respect you give to the seniors, it's very, heart-touching for us. And the conference which is held at the college, college is the place where we learn. It should be held in college only because it's a platform where we learn whatever the education we give, it should be given in a proper place like Gurukul, what we had in the earlier. Like that, the conferences or the seminars or the CMAs should be held in the college. That's what you have followed now. And also it's a platform to exchange the knowledge. And secondly, what I observed in the morning, all the seniors, the academic platform was equally distributed between seniors and the juniors. It was really, when you have such academic seniors, then automatically the juniors also will take the same path. So that's what I've observed since morning. It's really good, and my sir, Dr. Majumdar sir is there, who has been my examiner in my PG days. Hello, sir. So his blessings, and our sir, Rai Chaudhary sir is not there. So we read his book. Yeah, sir. We read his book in our UG days. So all this made us what we had today. And all the blessings and the teachings from my seniors has made us what we are today. It's nothing like we earned on own. It's all the given, and we have perceived it, and we have taken it forward, that's all. And as a president of our national AOI, the AOI is on good path now. And academically, it's doing very well. My past presidents, who is here, Dr. Deepak Haldipur and Dr. Samir and Dr. Dubey and Sanjay Agarwal, they all led the path for us to follow it. And we have come out with the guidelines. And in the morning on allergic rhinitis, the speaker was mentioning the Indian guidelines. I felt so proud that what we have done, it's been, taken by the AOI members and they're putting it on the paper. It's so good when we do some work and it's recognized by our own members. So we have done the Indian guidelines for allergic rhinitis, and same thing will be followed. We are on our way to do for giddiness, vertigo, then thyroid nodules, tracheostomy, and also we are on our way to make the consent forms, uniform consent forms throughout India for all the surgeries, so that anything, if at all it's legally there also, once it has come from the AOI, then the court will accept it. So that's what we are on our way. And also AOI, rather than, apart from this academic, we want to encourage everyone to do the research. That's what we are lagging behind, and we need to put ourselves into that. As a clinician, we feel like once we are surgeons, why we should do research? No, it should go both hand in hand. The clinical surgical acumen, what we learn, plus our research also. Like morning, I saw the research paper, best awarded research paper. It's good. Like that, we need to have good research paper as well as the innovations, the technological innovations, because we are very good at, making these things. So we need to encourage that. There are so many NGOs as well as so many government agencies which support this. Only thing is we need to know where to apply and get it sanctioned. So with these few words, I thank once again you people for showering on us such good welcoming and making us feel so homely. I thank you everyone. Thank you.
Thank you, madam. Thank you, madam. Now we take the opportunity to felicitate Dr. Deepak Haldipur, our past national president, AOI. He will be felicitated by Dr. Haradan Bora, our President AOI West Bengal. Dr. Deepak Haldipur is Senior ENT Consultant, Fortis Hospital, Vikram Hospital, Sagar Hospital, Cord Road Hospital, NR Hospital, Kareen ENT Hospital, and Honorable ENT Consultant, Indian Institute of Science. May I request Dr. Haldipur to say a few words from that chair only, please.
Age is something you cannot miss. They allowed Bharti to stand and speak, but they say I have to sit and speak. Obviously, it means age has caught up with me. But I feel very young because I can see in the front row Professor Mujumdar, who was my examiner as well, Dr. Baran Kumar Roy Chaudhary, who wrote our ENT book, with which we cleared our undergraduate exams. Tarun Polit sir is there, A.M. Saha is there. And the most important thing is I feel like a fish which has gone into water now. 2.5 years of COVID and no conferences, only webinars. You can always give a lecture online in AOI West Bengal conference, but then you don't get to eat the muri or the chai or the luchi puri or the hilsa and what all and what not. So you miss the Kolkata hospitality. I don't know how many visits I have made to Kolkata from that fateful day when Amitabh called me to Vivekananda Institute. That was, I think, 6 months before 2017, when I decided to contest for the AOI president election. Ever since then, I have been coming and coming. Hopefully next year again, 50th, you call me at least to deliver a vote of thanks, because I don't want to miss the hospitality. Thank you very much.
Thank you, Dr. Haldipur.
And one small word for this most charismatic man, Dwaipan Mukherjee. I think I call him we have these laddus. He's the glue who sticks all the particles of the grains together and makes it a good laddu. I think one of the finest organizers I have seen in my life.
Thank you so much, sir. Now may I request Dr. Kaushal Seth, our National Honorary Secretary of AOI, to come up to the chair, please. Sit in the chair, please. He is consultant ENT, robotic and sleep apnea surgeon. He will be felicitated by none other than Dr. S.N. Bandopadhyay, please. Hey.
Before Debashish says anything, I'm going to stand up. I can't be seated in front of all my seniors. Sorry. All right. I'm at a loss of words, and actually I'm going to say a very few words. I came to Kolkata, sorry. I came to Kolkata yesterday, but I never felt that I've left my home. As Bharti Madam has said, Deepak Sir has said, it's like a second home. The warmth and the hospitality that's offered to all of us is just amazing. In fact, since morning that I've been in this conference, I am amazed to see the bonhomie and the camaraderie between the juniors, seniors, PGs. It's just so amazing. It feels nice. It feels, I'm sure now AOI West Bengal is in good hands. It's got an excellent future. And as Dwaipan had requested, being the Secretary of National AOI, I'm going to extend my complete support for the 50th conference next year. And with these guys around, I'm sure it will be bigger than an AOIWBCON also. So thank you once again for this honor. I'm feeling very old actually to get this honor, really. So early on. Thank you.
Thank you, Dr. Kaushal. Thank you. He is a very humble, down-to-earth, very learned and true gentleman. He is what we all call Ajat Shotru. He is our editor-in-chief of Bengal Journal of Otolaryngology and Head Neck Surgery. He is responsible for indexing the journal in DOAJ, Index Copernicus, Google Scholar, OCLC, WHO Hinari, OL Star, BASE, OAJI, EZB and whatnot. He always strives to take our journal to newer height. He is the person responsible for single-handedly lifting the quality of Bengal Journal of Otolaryngology and Head and Neck Surgery. He was the immediate chairman, editorial board of Indian Journal of Otolaryngology and Head and Neck Surgery and contributed immensely there too. He is our very own Professor Somendranath Bandopadhyay. We take the opportunity to felicitate Dr. Professor Somendranath Bandopadhyay. May I request Dr. M.B. Bharati, National President of AOI, to felicitate Dr. Bandopadhyay, please. May I request Dr. Bandopadhyay to say a few words from the chair, please.
Good afternoon, dignitaries on the dais and the luminaries present here and the delegates. I am humbled to I'm humbled to address you in presence of such an august gathering. It had been an immense pleasure to nurture the Bengal Journal of Otolaryngology and Head Neck Surgery during the last 7 years. But I must express my gratitude to the executive committee, the reviewers, and the seniors for their guidance, and to the contributors from Bengal and from outside and abroad also for taking the journal to a new height. But I must also say that our journal is still a toddler and it cannot work without your support. So I again solicit your support for the Bengal Journal of Otolaryngology. Long live AOI West Bengal, long live AOI, and long live BJOHNS. Thank you.
Thank you, Dr. Bandyopadhyay. Now let me request Dr. Snehashish Bormon, Honorary Secretary of AOI West Bengal, to deliver his speech, please.
Respected dignitaries on the dais, my seniors and my colleagues. I have completed my 4 years as the Honorary Secretary of AOI West Bengal. It was a wonderful experience to work under the leadership of Dr. Shubhajit Banerjee, our outgoing President of AOI West Bengal. And I have enjoyed working with Dr. Utpal Jana, Dr. S.M. Bandyopadhyay, Dr. Amitabh Roy Chaudhary, Dr. Bidhan Roy, Dr. Devashish Guho, Dr. Manoj Mukherjee, Dr. Shormishta Bandyopadhyay, Dr. Soumitra Kumar, Dr. Diptangshu Mukherjee, Dr. Devangshu Ghosh, Dr. Ajay Khawas, Dr. Chiranjeev Das, and all the members of Executive Committee. I got advices whenever I needed from Dr. B.K. Roy Chaudhary, Dr. Shantanu Banerjee, Dr. Torun Palit sir, Dr. A.M. Saha, Dr. Devratan Nandi, Dr. Haradan Bora, and all my seniors. I take the opportunity to congratulate Dr. Ashok Dandopat, Organizing Chairman, Dr. Manoj Mukherjee, Organizing Secretary, and the team of Bardhaman for concluding successfully the 48th AOIWBCON at Sinclair Resort, Bardhaman on 1st and 2nd February 2020 when we met last time physically. And they have set up the benchmark. And for last 2 years, it was a tough time for every one of us. All our colleagues were fighting with corona pandemic from the front line. Our association has extended all kind of support to our members during this time. We have continued our academic activities on digital platform. AOIWB Digital PG Summit was organized on 7th and 14th March 2021 on Google Meet platform. Srimati Rashmani Mukhopadhyay Memorial Oration was organized in April 2021. The orator was Dr. Devodip Chakraborty, oral and maxillofacial surgeon. Dr. Abilal Mukherjee Memorial Oration was delivered by our President AOI, Dr. M.B. Bharti, on 26 September 2021. And monthly clinical meetings and journal clubs were also organized on the digital platform. Our new AOI West Bengal YouTube channel was created, and most of the programs were uploaded on this channel, and also our today's program is also live on our YouTube channel now. Our first online live surgical workshop was organized in August 2021 from Arjigor Medical College and Hospital, and 6 surgeries were performed by eminent surgeons of our association. We have conducted PG Orient program, an exam orientation program for the otolaryngology postgraduate training, and students from all the medical colleges have joined us, and teachers from all over West Bengal extended their helping hand for this program. I thank Dr. Dipankar Mukherjee for successfully organizing Dr. S.M. Sen, Dr. Torun Palit temporal bone dissection competition with increasing popularity. This competition helped many of our members and juniors to develop their surgical skills. We have observed World Hearing Day on 3rd March 2022 by doing social awareness campaign and also distributed 8 hearing aids to poor deaf children at free of cost on 5th March 2022. We appreciate the tremendous effort made by Dr. Indranath Kundu, organizing chairman, Dr. Debobroto Das, conference coordinator, and team of Arjikar Medical College to organize the mega show of 49th AOIWBCON after a long period of 2 years of repeated lockdown and restrictions due to COVID pandemic. I believe that this conference will be a grand success and all the delegates will return with happy memories. I thank Dr. Kaushal Seth, Honorary Secretary AOI of AOI, for attending this conference and delivering the prestigious Satyavan Ray Memorial Oration. I also thank Dr. M.B. Bharti, AOI President, and Dr. Deepak Haldipur, past President of AOI, for joining us despite of their busy schedule. I congratulate Dr. J.N. Gurtu for delivering Dr. Professor Sarada Prasanna Ghosh Memorial State Oration in this conference. We express our grief and sorrow due to the sad demise of some of our members. May their soul rest in peace. We have lost our beloved immediate past President of AOI West Bengal, Dr. Minal Kanti Acharya, fighting with COVID pandemic, and we pay our tribute to him by handing over the Lifetime Achievement Award to our Bodhi, Mrs. Anuradha Acharya, for his excellent services towards AOI West Bengal and ENT fraternity. I congratulate Dr. S.N. Bandyopadhyay, editor of BJHNS, for uplifting the standard and value of our state journal. Under the leadership of our new president, Dr. Haradan Bora, we will continue our work for the development of ENT fraternity. We will organize more programs for our members in coming years, and I request all the members to actively participate in all our programs. Long live AOI West Bengal, your obedient secretary. Thank you.
Thank you, Dr. Snehashish. With a heavy heart, we on behalf of AOI West Bengal are very proud and privileged to posthumously honor late Dr. Minal Acharya, past President AOI West Bengal, with Lifetime Achievement Award. I request Dr. Minal Acharya's wife and our very dear Anuradha Bodhi and her son to come to the dais and accept certificate and medal Mishti as token of sincere respect. I request Dr. Debobroto Das, conference coordinator, to accompany them to the dais, please. I request Dr. Doipayan Mukherjee and Dr. Snehashish Bormon, who were both like his own and dear younger brother, to do the honor, please. Other family members are requested to join.
tenure as the president of this prestigious organization is coming to an end today, and I am very much grateful to you all for electing me as the president of this association.
না না এদের না ওই অ্যাওয়ার্ড এই তোমার এই পেপার এই অ্যাওয়ার্ড এই অ্যাওয়ার্ডগুলো ডাকবো তো।
থ্যাংক ইউ অ্যাসোসিয়েশন, যা কিনা আমার হাজব্যান্ড ডক্টর আচার্যির প্রাণ ছিল। আজকে ভাবিনি কখনো যে এরকমভাবে স্টেজে দাঁড়াতে হবে ওর নামেই অ্যাওয়ার্ডটা নেওয়ার জন্য। ভীষণ ভালোবাসত অ্যাসোসিয়েশনের যত মেম্বার যারাই আছে প্রত্যেককে, আর অ্যাসোসিয়েশনেরও এই যে জুনিয়র সব ছেলেরা এবং আমাদের সিনিয়র সবাই, তারা যে তাকে মনে করে এভাবে সম্মানিত করেছেন তার জন্য আমি গর্বিত, আমি সম্মানিত। I am honored and very much privileged to be here to accept this award. Thank you everybody. Thank you all.
মৃণাল আচার্য আমার এক ছাত্র। এই কোভিডের সাবলে আমার প্রায় মৃণালকে নিয়ে 13 জন চলে গেছে। প্রথম ছাত্র ছিল, হয়তো ভারতী জানবে, প্রাণেশ শ্রীনিবাস, কোয়েম্বাটোরের নিউরোলজিস্ট। প্রাণেশ গেছে, সেলভালিঙ্গম গেছে, আরও অনেক যা গেছে, বাপরা গেছে, জয়পুরেতে আরও অনেক। আর মৃণাল এদের ভেতরে একজন, একে নিয়ে 13। একদিন সবাইকে যেতে হবে সেটা ঠিকই, কিন্তু তবু যেন মনে হয় একটা কে চলে গেল। তারা এসছিল তারকার মতো, চলে গেল ধূমকেতুর মতো কোন সে অযাত্রার পাশে। মৃণাল, তোমাকে যে মনে রেখেছে সেই আজকের ভিড়েতেই বোঝা যায়। তুমি শুধু ছবি নও, তুমি ছবির ওপরেও এখন আছো, আমাদের মনের ভেতরে আছো এবং থাকবে যতদিন আমরা বেঁচে থাকি। মৃণাল, আপনার মৃণালের স্ত্রী এসছেন, আমার মনে আছে কি সুন্দরভাবে আমাদেরকে নিমন্ত্রণ করে নিয়ে গিয়েছিলেন জলপাইগুড়ির কনফারেন্সে, লাস্ট কনফারেন্সে। আজকে আনন্দের ভেতরেও এই এক বেদনার এক মুহূর্ত মনে থাকে, তুমি বেঁচে থাকো।
Thank you, sir. Now we'll have our award presentation ceremony. I'll request Dr. Shubhajit Banerjee and Dr. Haradan Bora, our immediate past president and our immediate president, to hand over the awards, please. Hey, ready, Tomra? Award? 13, Dr. S.M. Sen and Dr. Tarun Palit Temporal Bone Dissection Competition. First award goes to Dr. Junior category goes to Dr. Nandini M.K., who stood first in junior category. Dr. Ushrin Basu stood first in the senior category. এটা তো হবে না, এটা তো 14, এটা তো নেক্সট ইয়ার পাবে। Dr. Savika Zaman and Dr. Shayan Hajra stood first in the senior and junior category, and in the 14th SM Sen and Dr. Tarun Palit temporal bone dissection competition, and their award will be given in the next conference. May I request Dr. Award for monthly clinical meeting year 2020 goes to Dr. Oshim Sharkar. Dr. Usrin Basu is getting the award now in the senior category. I request Dr. Oshim Sharkar, Dr. Debobroto Das and Dr. Pokriti Shomadar, all of them stood first in the monthly clinical meeting with equal number of points, to come to the dais. Dr. Oshim Sharkar, Dr. Debobroto Das and Dr. Pokriti Shomadar. Yeah, 2021 to 22. Pabe to. For the year 2021, Dr. Titasha Pakira stood first. Hai Nandini ache. Nandini. Ache. Lunch korte hobe. Lunch kore de. Huh? You take. Huh? No. তোমার নাম বলো। ওকে তাহলে নিয়ে নি, ওখানে ওরা দিয়ে দেবে। I request Dr. Titasha Pakira, Dr. Dipanjan Chakraborty to come to the dais, please. They got the first and second award for the monthly clinical meeting. No, আসেনি। Dr. Chiranjeev Das, Dr. Pritam Chatterjee, Dr. Chiranjeev Das, Dr. Pritam Chatterjee, Dr. Shishak Dotto, Dr. Nazrul Malik, Dr. Shorbesh Asgaonkar, Dr. Ramanuj Sinha, and Dr. Birashwar Bishwas. এটা বল। কেউ আছে? Service come? এই গ্রুপটা যাচ্ছে রামানুজ সিনহা অব্দি, যেটা এই অব্দি। তিতাসা ওখানে দাও। তিতাসা Dr. Shishak Dotto, Nazrul Malik, Dr. Shorbesh Asgaonkar, Dr. Ramanuj Sinha, Dr. Bireshwar Biswas.
কোনটা এত তাড়াহুড়ো করছিস কেন তুই?
আরে তোমার দুটো বেজে গেছে, দুটো সেশন তোমার পিছিয়ে গেছে। কিছু লেখাই নেই, আমি তো জানি না, বললাম না।
কিসের জন্য এটা?
PK. This is for Dr. PK Khashnobish Award for Best Article in the Journal, Bengal Journal of Otolaryngology Head Neck Surgery. For the year 2020.
21.
Sorry, for the year 2021. For the year 2020, the award goes to Dr. Chiranjeev Das and Dr. Pritam Chatterjee.
Dr. Asim Sarkar, winner of monthly clinical meeting award for the year 2020.
এই ওদেরকে একটু এগিয়ে আসো, ওদেরকে খুঁজতে আমাকে আরে পাশে
Dr. Shishak Datta receiving the PK Khashnobish Award, accompanied by Dr. Sarvesh Ajgaonkar. Dr. Asim Sarkar. Oh, no. Achha, sorry. Dr. Sarvesh Ajgaonkar receiving the PK Khashnobish Award for the year 2021. There are three contributors for the article published in BJHNS in the year 2021. Okay. Now, Dr. Asim Sarkar, you are the winner for the year 2020 monthly clinical meeting. Nanni? তাহলে তুই যা নিয়ে না এটা সব উল্টো। ডক্টর অসীম সরকার, ডক্টর অসীম সরকার, অসীম তো ছিল তো। নেক্সট রেডি করো। ডক্টর রামানুজ সিনহাটা কোথায় রেডি আছে? স্যারেরটা রেডি আছে কোথায়? Doctor, may I request Dr. Ramanuj Sinha to receive the PK Khashnobish Award for the year 2021. Chiranjeev, please come on the dais. Chiranjeev, please come forward. Dr. Chiranjeev Das, winner of the PK Khashnobish Award for the year 2020. Article published, Sure Shot Technique for Management of Ranula, BJHNS 2020, Volume 28. Next, Dr. Misbaul Haq, winner of Dr. Major KK Ghosh Award at the 48th AOIWBCON. Misbaul, are you here? Then Dr. Devabrata Das, please come on the dais. Misbah. Dr. Misbaul Haq, winner of Major KK Award at Bardhaman Conference 48th AOIWBCON.
Now, Dr. Devabroto Das, winner of Dr. D.K. Roy Consultant Award at 48 AOIWBCON.
Again, Usrin Bose, please come on the dais to receive Dr. Shantanu Banerjee Video Award at the 48th AOIWBCON. Dr. Preeti Rubinath, Dr. Preeti Rubinath, Dr. Usrin Bose, please receive the Dr. Shantanu Banerjee Video Award for the year 48 for 48th AOIWBCON. Usrin Bose. Usrin Bose.
তোকে সার্টিফিকেটটা আগেই দিয়ে দিয়েছে বুঝছিস তো
Then Dr. P.V. Mukherjee E-Poster Award, 48th AOIWBCON, winner Dr. Preeti Rubinath. Dr. Preeti, please come forward. Then Dr. Sujas Banerjee and Dr. Dipanjan Chakraborty. Dr. Sujas Banerjee, Dr. Dipanjan Chakraborty, winner of Dr. S.N. Chaudhary, Dr. P. Chatterjee ENT Quiz Award, 48th AOIWBCON. Sujas and Dipanjan. Dipanjan? Oh, Dipanjan. And we had a AOIWB Digital PG Summit organized on 7th and 14th March 2021. There the paper presentation, the winner was Dr. Debolina Mojumdar. First prize Dr. Debolina Mojumdar, second Dr. Divya Sethi, and third Dr. Safika Jaman. And for e-poster, the winner was Dr. Uday Shankar Roy. Uday. And second, Dr. Spondita Ghosh. And third, Dr. Obhijit Das. There were two third. One is Obhijit Das and one is Dr. Purvita Mitro. Acha kyo? The first online program, AOIWB Digital PG Summit. It was organized during the COVID lockdown period. ठीक है और तू यार देवाशीष दा এটা কে কি নাম কি জানো পূর্বিতা আর ওটা কে নিচ্ছে ওর নাম কি Debolina Mojumdar is receiving the first prize for paper presentation in AOIWB Digital PG Summit. Dr. Purvita Mitro receiving the third prize in the e-poster in the AOIWB Digital PG Summit.
That's all for the awards presentation ceremony today. Now may I request Dr. Devabroto Das, our dynamic conference coordinator, for giving vote of thanks, please.
কি নাম কি নাম বল স্পন্দিতা ঘোষ কোন ক্যাটাগরি তো শুরু করি দাঁড়াও ফটো সেশন শেষ হয় আচ্ছা হ্যালো সো নাও দি ফাইনাল ওয়ান ইজ দি ভোট অফ থ্যাঙ্কস আমি এই প্রথমবার ভোট অফ থ্যাঙ্কস দিচ্ছি সেই জন্য একটু নার্ভাস ফিল করছি আর কি যদি ভুলচুক কিছু হয়ে যায় তাহলে পার্ডন মি I have a great pleasure and honor to convey our sincere thanks and gratitude to Dr. Sudipta Roy, MLA and Chairman, Rugi Kollan Samiti, Arjikor Medical College, Chief Guest, and Professor Bikash Ghosh, Principal, Arjikor Medical College, in charge, special guest, for sparing some time from their busy schedule and attending the inauguration ceremony of the 49th AOIWBCON 2022. I am also grateful to our senior member, Dr. Satyabroto Banerjee sir, for inaugurating this conference. We are also in debt to Madam M. Bharati, President of AOI, Deepak Haldipur sir, past President, and Kaushal Seth sir, the Honorary Secretary of AOI, to take pain in spite of their busy working schedule to come and participate in this conference as guest faculties. It would have been not out of place to convey our sincere thanks to our HOD, Departmental HOD, Dr. Indranath Kundu, Organizing Chairman, and other members of the organizing committee for their effort in organizing this 49th annual conference of AOI West Bengal, Arjikor Medical College, at Arjikor Medical College, Kolkata. I thank our President Shubhajit Banerjee sir, the outgoing President, Dr. Haradhan Vora sir, our President, my beloved Dada, Dr. Snehashish Bormon, again my another friend, philosopher, guide, sir, Dada, the Honorary Secretary, Dr. Doipayan Mukherjee, Honorary Treasurer, and all the members of the Executive Committee AOI West Bengal for giving their valuable guidance and support in making our program a grand success. I thank Dr. Manoj Guho of Coach Bihar, Dr. Bidhan Rai of Holdia, Dr. Anirban Ghosh of Raniganj, and other members for extending their help in raising the fund for organizing this conference. I thank the authority of Arjikor Medical College, Kolkata, the Stadel Hotel, the Escar Decor, the audio-visual persons, and all the vendors for providing the technical support and the excellent service. I thank all the patrons and participants of the trade exhibition who have extended their helping hands. I cannot forget to give heartfelt thanks to all the honorable delegates for participating in the conference and making it a grand success. Thank you.
Thank you all.
নম্বরটা দিয়ে দাও।
We are starting our next program, requesting all the delegates to enter inside the auditorium and enjoy the academic feast. Our next program, invited talk by Dr. M.B. Bharti, our President AOI. Topic,
Next slide, next. nahi aata na? Okay.
role of total laryngectomy in the...
It's changed.
Oh, sorry.
Parapharyngeal space tumors.
The topic is parapharyngeal space tumor, and I request Dr. Dulal Bose, please come on the dais, and Dr. Devashish Guho. Oh, Dr. Shekhar Bandyopadhyay. Dr. Shekhar Bandyopadhyay. Please come on the dais and as chairperson of the session.
টাইমটা বলে দিতে হবে। এই আমি বলে দিয়েছি Dr. Bharti MBA, she is the president of Association of Otolaryngologists of India. She is senior professor and former head, Department of ENT, Head and Neck Services, JSS Medical College attached to JSS Academy of Higher Education and Research, Mysuru. She also heads the Head and Neck Services and Cochlear Implant Program at JSS Hospital. She is a BC Roy awardee and has received the Best Teacher Award. She is also awarded with medals at various conferences for her scientific contributions. One of the nominee for Margaret F. Butler Outstanding Mentor of Women in Head and Neck Surgery. She has received Lifetime Achievement Award. She has published more than 65 publications in national and international journals. She has been invited faculty, operating and speaker in various national, regional and international conferences. Main area of interest are head and neck tumors, cochlear implant, skull base and airway surgeries. She is an undergraduate and postgraduate teacher and has involved in various research work. She has organized 2 national and state, South Zone conferences and live surgical and cadaveric workshops. May I ask Dr. Mrs. M.B. Bharati to present.
Thank you, sir. Thank you, sir. Respected chairpersons and my dear friends, first of all, I thank my friend Dr. Dwapan and Dr. Snesis Baman and the entire team for inviting me to be here. And actually, I was supposed to talk on role of total laryngectomy in the era of organ preservation protocol. The pen drive, the last 2 weeks was very busy, and so the pen drive, I forgot to get it. So this, I just got it from this is the thing which we had done. And in the night in the airport, I did some video editing, and here also I was doing. So this is how it goes. And I'll be talking about parapharyngeals, and also my computer is not giving me the trouble, like PPT I cannot make only, I cannot edit. So I've just put this and I'll be talking on that. This is the study which we retrospectively analyzed our results of parapharyngeal space tumors. I have very passion for this parapharyngeal space tumors since beginning. Since I think 1998, I'm doing parapharyngeal space tumors. And you know, you should always have passion. Like whenever you are a surgeon, you have passion for some areas. Like that, I have passion for some areas. Laryngectomies, all surgery, all laryngeal surgeries, and in the head and neck for the parapharyngeal space tumors. And so night I thought, okay, I'll present on this only. And this was analysis of 5 years. In 2017 January, 2015 to 2021, we had 31 parapharyngeal space tumors. Neurogenic is 52%, salivary gland origin is 48. Among neurogenic, we had 11 cases of schwannomas and 1 vagal neurofibroma, and then 4 paragangliomas from the carotid. And this is the 19 females and 12 males. Age group was 35 to 50 years. Most common presenting feature is neck swelling followed by oropharyngeal mass. Other symptoms includes pain, dysphagia, fullness, change in voice. And I'll be talking, presenting my video. So as you all know, the parapharyngeal space is a deep-seated space. The base is at the skull base, and then apex is at the aortic bone. And it has 3 parts. Before we used to, when I started my interest with this, we had only pre-styloid compartment and the retrostyloid. But now the retrostyloid compartment is, we can also call it as supra-aortic carotid space, okay? And then we have the medial mucosal space. That is all the tumors which arises from the nasopharynx and enters into it. We call it as a mucosal, medial mucosal space. And because the tumor is so deep-seated, like this is the cadaver dissection we did. This is the pre-styloid. This is the retrostyloid compartment. In the retrostyloid, we have the internal carotid artery and the internal jugular vein and the lower cranial nerves. Because as I told you, it's a deep-seated space, a tumor of at least 2 to 3 centimeters, it has to be of that size for it to become clinically either shown externally or in the oropharyngeal mucosa. Whenever we have oropharyngeal swelling, okay, a smooth swelling, so clinically only we can make out whether it is a pre-styloid compartment or retrostyloid supraoid carotid space. How? Whenever, if it is a pre-styloid, so only the palate and the tonsil is pushed medially. Whereas if it is a supraoid space tumor, carotid space tumor, then the lateral pharyngeal wall bulge will be there behind the posterior pillar, and entire tonsil is pushed anteriorly. Okay? So this is how we make. And clinically on examination, we can make out in the retromandibular fossa, fullness will be there. And we can have, along with the dysphagia, stridor, hoarseness, then unilateral effusion, otalgia, Horner's syndrome, then the dysarthria, possible tinnitus, bruit, thrill, hypertension, flushing, depending on the extent of the tumor and what type of tumor you are dealing with that. Now, any assessment clinically, after clinical, it's a radio imaging, and then our cytopathological diagnosis which helps here, okay? We had to be, before when I started, the imaging technique was not very good and no one understood exactly properly what's a parapharyngeal space and what are the characteristics we see on MRI, T1 and T2. But now with the advance of technology, we are very good and we can easily make out with the scan, whether it is retrostyloid or pre-styloid or medial mucosal space. And also our cytopathology is very good now. So they can easily, like you do transoral cytology, or if the tumor is there in the retromandibular fossa, then you can do FNSC from outside only. So it will give you an idea what exactly the cellular origin Because whenever we know the cellular origin, we can plan properly what we should do. And also the radio imaging will help us what will be the extent of the tumor, and this tumor can I go through transorally or externally, that is endoscopic transorally or external approach. So these are the factors which we come out. In the checklist we write what is the tumor, where it is, and whether the internal carotid artery is pushed anteriorly or posteriorly, and then whether there is a fat plane between the tumor or and the deep lobe of the parotid. This is important. All these points we'll look for whenever we are dealing with the radio imaging of parapharyngeal space tumors. Here you can see on MRI, you can see this is the hyperintense on T1. You are seeing lateral here. And then the anatomic relations, we have anterolateral, posterolateral, and medial. So this is the anterolateral aspect. And then we have the anterolateral, we have the infratemporal fossa. And then posterolaterally, we have the parotid space and the mesenteric space, and then medial mucosal. So here in the anterolateral masticator space, and these are the muscles you can make out. This is the medial pterygoid muscle, this is the lateral pterygoid muscle, this area is the infratemporal fossa, and then this is the mandibular ramus. And then posterolateral aspect, we have the parotid space, you have the parotid superficial lobe, the deep lobe, the external carotid artery, retromandibular vein here. That is the important landmark which we usually see here. And this, when we cross a line along the styloid process, so this is your pre-styloid compartment, this is the supraioid carotid space or retrostyloid compartment, which contains all this, internal jugular vein, the internal carotid artery, and lower cranial nerves. And then usually the retromandibular vein, we follow it up. That is only possible when you see through the soft copy of this. Then that's what I was telling, this is the pharyngeal medial mucosal space. And what we see in all these schwannomas or neurofibromas, we have a non-enhancing lesion in the parapharyngeal space. These are the few examples. In the sagittal plane, the non-enhancing, and this is the, you can see well-enhanced lesion, which is seen in cases of carotid body tumors. This is the life science playing of internal and the external carotid artery. Now, what are the approaches we have? We have external approach and we have transoral endoscopic approach. So, when to apply each? So, any tumor which is posteromedial aspect, you can always go for the internal approach, that is transoral endoscopic approach. And the pre-styloid depends what, if at all the pre-styloid compartment tumor is there, and usually it will be the either the lymph nodes or the salivary gland tumor, which is arising from the minor salivary gland present in the pre-styloid compartment, or it will be the extension of the deep lobe of the salivary parotid. So if at all it arises from the minor salivary gland, then on the scan we have the free fat plane between the mass and the deep lobe of the tumor. So that says it is the tumor which is arising from the minor salivary gland in the pre-styloid, and you can go ahead with your transoral endoscopic approach. Whereas if the no fat plane is there, that is the deep lobe is extending into the pre-styloid compartment, then that also, if it is very small, you still can go ahead depending on your whatever it is, but best is to go the external approach. I'll be showing it now. So before going, I'll just show in the cadaver. See, always we learn from our cadavers, so we need to respect the cadavers. What are the external approaches we have commonly done? I'm not going for all those infratemporal fossa approach and all here. Transcervical approach. So this is the upper skin crease incision, which 2 centimeters or 2 finger breadth below. Why we keep the 2 finger breadth below is we don't want to damage our marginal mandibular nerve. Always the marginal mandibular nerve, if at all it is there, below, it will be within 1.5 centimeter from the angle of the mandible and the lower border of the mandible. So you need to protect the marginal mandibular nerve. So always we use that incision at that level. Then how to gain the access here. So the submandibular gland either you can remove depending on your tumor, whether if it is very big you remove it, otherwise you can displace it, dissect lowerly on the lower aspect and displace it anteriorly and medially like this, or you can remove it. Then the other way of gaining, making the wide area is to cut the digastric tendon. And third is the stylomandibular ligament, you just lift it. You lift the mandible and the stylomandibular ligament gets stretched. So these are the three ways to increase your area of access to this parapharyngeal space tumors. So this is the parapharyngeal space, and then digastric muscle cut. And then this, if at all this is a tumor, like by blunt and, alternating blunt and sharp dissection, we deliver the tumor out like this. This is the transcervical approach. Then the next commonly used is the transcervical transparotid approach. This is for the deep lobe of the tumor, which is extending onto the prestyloid compartment. So this is the same incision, modified Blair's incision, little more into the neck we extend. And then you can see the facial now. This is the superficial lobe. We reflect it anteriorly. Facial trunk we identify. And then these days we pass the endoscope and see all around. I'll be showing in my videos. And then we remove the deep lobe of the parotid. But this can be done only if the FNAC is, benign. If at all, and you should be very careful. There should not be any spillage of these tumors, especially with the parotid gland tumors. And this is a transcervical transmandibular, very huge tumors extending onto the skull base. We make paramedian mandibulotomy, go along the floor of the mouth till the anterior pillar, and then this will be your parapharyngeal space, and then we'll remove the tumor. This is a transcervical approach. Use a subplatysmal plane, we elevate, then we open the cervical fascia. You can see. This is the carotid. This is the submandibular which has been reflected. And this is the hypoglossal now. You can see the tumor here. Here MRI did not show us the nerve of origin. It's very difficult. They say we can, but somehow, I don't know, our radiologists are not able to see the nerve of origin. Here, this is the nerve of origin. Anyway, it was not the vagus now. And then with the endoscope, you go on all the sides in the parapharyngeal space and see if there is any vascular supply for it. And then once you are sure that there is no much vascular supply under surface, then with alternating blunt dissection, the nerve of origin is cut, we dissect it out. The schwannoma and the neurofibroma. Schwannoma is just it arises out. So whenever we are removing schwannoma, the nerve of origin can be saved. But if it is neurofibroma, we cannot save the nerve of origin. This was one of the branches of the sympathetic plexus. So this patient had Horner syndrome afterwards. This is the parapharyngeal space internal carotid artery. This was then we filled with Surgicel, and then digastric muscle was sutured back. And this is transcervical you can see I told you all the prestyloid compartment, they push the tonsil medially and you have the bulge of the soft palate. So transcervical, then we extend the incision, modified Blair incision. The submandibular is pushed, reflected anteriorly and medially. Then the cervical fascia this is the great auricular now, is cut from the fascia along the sternocleidomastoid muscle, and then superficial lobe of the parotid is reflected. And then we identify the main trunk of the facial nerve. Yeah, you can see the main trunk of the facial nerve and its branches. Once we identify that, we pass the scope under the deep lobe or under the mass, and then we identify on all aspects. And to see for any major vessels. After that, the blunt dissection, we remove the tumor out. And then this is the parapharyngeal space. Pass your scope and see. This is the facial nerve under surface. As this was pleomorphic adenoma, there was no need to remove the superficial lobe. Then put back, and then we suture it. This I'll show later. Now coming to the carotid body tumor. You can see the light sign. This was the length of the tumor. See, we all know the carotid body tumor arises from the paraganglion cells in the adventitia. So we do subadventitial dissection. So whether to do pre-op embolization or not, we don't do pre-op embolization. Many of them don't do because it induces inflammatory reaction and fibrosis. As we are dissecting in the subadventitial plane, then chances of injuring the carotid artery, that is weakening of the wall, may be there. So we don't do that. And then we dissect the common carotid artery, external carotid artery, then we internal carotid artery, and the undersurface of it where the tumor commonly arises, we separate it. This is Chamberlain type 2. Type 3 usually we do with the vascular surgeons. We pass the tape around 2 of them. And only now which runs here underneath is the supralaryngeal nerve, we have to be careful. Above will be the hypoglossal nerve. These are the 2 nerves which we can injure. So with bipolar cautery and good watering, this is hypoglossal nerve, you can see here. We dissect the tumor slowly out. Now coming to the endoscopic. This is the cadaveric dissection. We make an incision anterior. You can see this is the tonsil, which is on your right side, on the medial aspect. Your dissection is lateral to the tonsil and the superior constrictor muscle. And then laterally you have the lateral pterygoid muscles, and posteriorly we have the stylopharyngeus and the styloglossus muscle. This is the branches of the inferior alveolar nerve. And then the stylopharyngeus muscle runs across, we need to cut it if at all the tumor is very big. And then this is the styloid process. This is the carotid artery. This is the, 46-year-old male. He had a, you can see here, non-enhancing lesion, left parapharyngeal space. The vessels are pushed posterolaterally. Tonsil, all like tonsils, only thing is we use the endoscopes and we retract. Incision is done on the medial aspect. We separate, go through the superior constrictor muscle. See, whenever the lesion is there, because it is pushing the wall medially, as soon as you make an incision, you will be on the surface of the tumor. You cut these muscles. Even stylopharyngeus muscles also will be cut. And then go laterally first. Identify this is the internal carotid artery. protect it, and then your dissection is very easy. Once you protect the internal carotid artery, there's nothing, no other structures comes here. I think patients are usually guiders. This was before I used to, I had done one without endoscopes. That was one female patient who wanted me to do without any scars externally. So I took courage, and after that I thought we can do. This is dissecting the lower bone, upper bone, sorry. You can see one parapharyngeal group of lymph node here. And once the FNAC says it is schwannomas, you can be very sure, even if you puncture the capsule also, there will not be any seedling. And then we close layer by layer. Riles tube insertion is done. For 2 days we give riles tube feeding. After 3rd day, we remove the riles tube, and the patient can go home on the 4th day. This is another tumor, hyperintense lesion on the T1, a vascular tumor. She had undergone surgery outside, but somehow the histopathology was inconclusive. They had done biopsy. This is the scar you can see. This is one of the rare cases of veno-lymphatic malformations which occur in the parapharyngeal space. So because it was very thick, I could use it as a retractor. We put the suture over the upper layer. These are the phleboliths which you are seeing. Yeah, now we get on to the proper tumor. Usually my assistant will hold the scope. This I'll skip. This is another tumor, Jane schwannoma. It was rising from skull base to the aorta. So whenever the tumor is very big, then we need to give a V-shape incision. That is, we make an incision on the medial and the lateral aspect. This is the incision we gave. First I thought I can with a single incision, made an incision separated, but I could not get on to the lateral aspect of the tumor. So then I opened the capsule, debulked the tumor. Yeah, opened the capsule, debulked it, and then you can pull the tumor medially, you can see the base, and then you can excise the tumor. This was pre-operative. This was post-operative after 1 month. And this is pleomorphic adenoma in the pre-styloid compartment. We all usually palpate it. Slowly we dissect in layers. Otherwise, it's the same. We get onto the base and then we remove the tumor. Usually place the surgicel and we close in 2 layers. And this is the neurofibromatosis. The patient had vagal neurofibroma. She came with hoarseness and difficulty in breathing. internal jugular vein. It is huge tumor, slowly separated from the internal jugular vein laterally and the carotid artery medially. You can see the nerve of origin here. So the carotid artery, it was extending up to the subclavian artery. Slowly dissected from it. Here was the subclavian artery. And then we cut both the nerve, both the ends. After conforming, we had, especially Horner syndrome we had, but it and then this patient had a massive aspiration in the first month because we did grafting also for her, the intervagal nerve grafting we did. Sural nerve we took and we did the grafting as well as thyroplasty we did. You can see the subclavian. But now she is doing fine. But immediate post-op, they'll have a stormy period. So this is the sural nerve we took, grafted. So we can do both endoscopic as well as the external approach for parapharyngeal space. It depends on what we are dealing with. If at all you are dealing with deep lobe tumor extending onto the parapharyngeal space, better to go transcervical, transparotid. And if at all it is a retrostellar, that is supraortic carotid space tumor, if the tumor is lateral to your internal carotid artery, then we cannot go transurally, because if you go transurally, you need to cross the internal carotid artery and then go. So that condition also we cannot, we have to go for transcervical. Other cases where the tumor is medial, posterior-medial aspect of the parapharyngeal space, you can easily go endoscopic transoral approach. And then even for these days, we are doing for malignancies also, I have not included in this. And there are in the literature, they are published for malignancies also, the endoscopic approach. That is, you have the parapharyngeal group of lymph nodes, thyroid metastasis into them, those areas, or any malignancies originating there. They have done a transoral endoscopic approach. So it's a good approach. These days, even robots they are doing. But I'm happy because I have only the endoscopes. I'm happy with the endoscopic approach. Thank you.
Thank you very much, madam. What is nice paper you presented as such. Parapharyngeal tumor as such, we are very often see in our practice are doing surgery as a whole. But your endoscopic approach of this is the new approach that I am hearing. It is so nice. We are thankful that you have demonstrated nicely.
Thank you,
Once
sir.
again, I am thank you.
Thank you, sir.
And one very important take-home message for the youngsters, Madam has conveyed that cadaver dissection plays an important role in all this. And I would like to request all our youngsters to go for cadaver dissection before going for these surgeries.
Yes. Yes, cadavers are the one, like you learn from your teachers and from your cadavers and from your friends. So all these three you respect, and then you learn and become academically good.
Thank you, Dr. Bharti. I request Dr. Utpal Jana. Dr. Utpal Jana, please hand over the memento to our chairperson, Dr. Dulal Bose, Dr. Shekhar Bandyopadhyay, and Dr. Devashish Guho. And our next program is panel discussion. We are running very short of time, so I request all the panelists to come on the dais. And Dr. Bharti, Dr. Deepak Haldipur, Dr. Kaushal Seth, Dr. Arjun Dasgupta, Dr. Kamalendu Haldar, and Dr. Anandabrata Bose. Dr. Anandabrata Bose, Dr. Kamalendu Haldar, Dr. Arjun Dasgupta, and our moderator, Dr. Doipan Mukherjee.
Everything was smooth. ठीक है ये भी कुछ नहीं पड़ा. We will do something.
मुझे लगता है ना माइक दे माइक and make them come. या तो you first try to.
No, I don't see. I don't want to do a small shoulder now for a big.
So we are in the fag end of our scientific session. We are having this panel discussion for 45 minutes, but as because we are running short of time and just after this panel we will have our general body meeting. So we will cut short the panel discussion so that we can start the general body meeting immediately after this panel discussion. So our topic of discussion is outcome of functional endoscopic sinus surgery, practical approach. We are having in the panel Dr. Deepak Haldipur from Bangalore, Dr. M.B. Bharti from Mysore, Dr. Kaushal Seth from Mumbai, Dr. Arjun Dasgupta from Kolkata, Dr. Anandabrata Bose from Shiliguri, and Dr. Kamalendu Haldar from Kolkata. Before starting the panel, I just like to congratulate Dr. Deepak Haldipur because in this COVID period, he had started his own multi-speciality hospital, that is Trustwell Hospital. Am I right? Okay, so chronic rhinosinusitis, the treatment of chronic rhinosinusitis, one of the option is surgical treatment, and functional endoscopic sinus surgery is advocated and practiced as the surgical treatment of choice for refractory chronic rhinosinusitis. The main goal of doing FACE in CRS are to remove the disease load, conserving the healthy mucosa, restoration of the ventilation and drainage pathway, and improve access for topical medical therapy. But the main role of any types of surgery here is adjuvant along with medical therapy, because ultimately at the end of the day, chronic rhinosinusitis is an inflammatory disease. So main treatment always will be the medical treatment, and we are having this adjuvant role of surgery to treat the functional endoscopic the disease of chronic rhinosinusitis. Now, for chronic rhinosinusitis, usually we are trying maximal medical therapy prior to the operation. So we are different sorts of options for maximum medical therapy. douching, corticosteroids, decongestants, antibiotics, antifungals, antileukotrienes, allergen avoidance, and immunotherapy. So I will like to ask this question to Dr. M.B. Bharti. What is your opinion regarding this maximal medical therapy and the preparation of functional endoscopic sinus surgery? Preparation of functional endoscopic sinus surgery prior to the operation.
Okay. Like whenever the maximal medical therapy fails, then we go for the functional endoscopic sinus surgery. So when we call it as maximal medical therapy, like 2 pulses of steroids in a year if the patient doesn't have improvement. And then we have done a proper douching, like you have advised the patient, and then corticosteroids I've told. Then decongestants do not have any role unless until it's a very boggy mucosa. Only for 5 or 6 days we give. And then antibiotics, yes, it has a role. Either it's an inflammatory immunomodulator antibiotics, or the culture sensitivity proved antibiotics we have to use. So that is there. Antifungals in allergic, it's not there. Only in invasive fungal infection, we have the antifungal role, not for otherwise. Then antihistamines, yes, if the allergy is the role you have. Then allergen avoidance, yes, if eosinophilic allergic CRS is there, then avoidance allergens, then antihistamines, they have the role. Then immunomodulators have the role, immunotherapy has the role.
Okay. Dr. Kamalendu Haldar, do you have any specific choice of antibiotics?
Now, antibiotic is a culture sensitivity if that a particular antibiotic. Otherwise, in cases of that, there is a polypoidal chronic rhinosinusitis or the non-polypoidal. The chronic, the chronic, this is the polypoidal cases in the doxycycline. This is not used as not the antibiotic, but it is a immunomodulator. This is a short course of 100 milligram daily for 3 weeks. But in cases of the non-polypoidal, that is a macrolide, normally we clarithromycin in a low dose, 250 milligram daily for 2 to 3 months.
Okay. Dr. Deepak Haldipur, you have advocated in some of the cases we can actually use antifungals. So what is your opinion regarding antifungals, and do you have any special preference of antibiotics in your day-to-day practice?
See, in patients who come to me with recurrent ethmoidal polyposis, especially within 2-3 years after surgery somewhere else, or sometimes done by me, they come back with polyposis. I have tried this itraconazole as a preparation for about a month or 2 in AFRS. It has worked very well. I have seen the polyps actually vanish. As far as antibiotics are concerned, if it is acute sinus, I have 2 clear classifications. Diabetic, non-diabetic. In diabetic, I am very aggressive because I can't wait for 8 weeks. Now we have this fear of mucor also, which you have to keep on thinking. So I would straight away go ahead with co-amoxiclav, maximum dose for 2 weeks, followed by metronidazole, another 1 week, which can cover the anaerobes. If it's a diabetic, I repeat the scan after 4 weeks. If the disease is unchanged, I operate. If it is a non-diabetic, I go by the textbook, wait for 8 weeks, and then I operate. Polypoidal is a different matter. I totally agree with Haldar that I may give steroids, I may give polypoidal doxycycline up to 8 weeks. Non-polypoidal clarithromycin, but I don't give that immunomodulator dosage, regular dosage to 500 mg OD or BD for 6 weeks or 8 weeks.
There are lots of debates regarding this immunomodulator role of the antibiotics, because now we are heading towards the phenotyping and endotyping of the diseases. And Dr. Kaushal, do you have any comment regarding the role of measuring IgE or eosinophils at the time of preoperative preparation to choose your antibiotics, whether you will prescribe doxycycline or macrolides? Like that. And another thing, I know you are doing immunotherapy on regular basis. So what is your opinion on that also, sublingual immunotherapy?
So before I answer your question, out of all these points, if you ask me, for me, douching is the most important one. Okay, because that helps in clearing of the mucosa, the mucus, restores the ciliary function also. So unless you advocate vigorous douching, the antibiotic therapy, decongestant to a certain extent, even the corticosteroids will not work properly. So douching, as you've rightly put in as the first point, should really be something that should be advocated. All right. Now secondly, serum IgE levels. If the levels come as too high, say in 4 figures, 2000s, 3000s, 4000, definitely you need to look into the allergy component also of this. Unless the serum IgE levels come down, the other therapies are not going to work.
Okay. And
So
you will advocate immunotherapy also in
So I
those
would
cases?
subject the patient first to a skin testing.
If anybody present here to participate in quiz contest, then the preliminary round is going on in the hall B, so they can attend the quiz competition in hall B. Okay, so now we come to the radiology part. So with this discussion, the take home message is maximal medical therapy should be tried in all cases of chronic rhinosinusitis, and we should explore all the options, and we should try our level best to continue that medical therapy. And if we cannot control the disease, then we can proceed for the functional endoscopic sinus surgery. And in this era of litigation, it is also very important to satisfy the patient. So those candidates are the ideal candidates for our surgical option. Now I come to this point to Dr. Arjun Dasgupta. How can we derive maximum information from a preoperative CT scan?
When a patient had a maximum medical therapy, as has been discussed quite in details in before, if the patient is still symptomatic, we will have to do a CT scan, try to find out the extent of the disease, and if there is any correctable pathology which will not be amenable to standard medical therapy. So that's how the CT scan should be done. It should be a 1 millimeter cut. It should be done in coronal, sagittal and axial section. Coronal mainly for diagnosis, axial and sagittal for operative. Where I don't give contrast routinely unless there is a history of bleeding or I can see a mass in there already. And with the Lund-Mackay scoring, we can assess the severity of the sinusitis, and that is good if in case the patient have non-resolution of the symptom post-operative, and we do the CT scan, we can compare them and compare with the preoperative CT scan.
Okay, so CT scan is very important for the face surgeon because this is the roadmap for the entire procedure, and we must try our level best to elicit maximum amount of information by reading the CT scan. Now this is for Dr. A.B. Bosch. How do you ensure adequate visualization and reasonably dry operating field, because this one factor is directly related with the final outcome of the operation?
I think as has been mentioned, I think treating the patient medically before surgery is probably the utmost important, which includes not only the management as far as the nose is concerned, but other associated factors of blood pressure and diabetes. And if you optimize these things, your field is going to be better. Giving antibiotics and steroids, if possible, makes it even better. A good understanding with your anesthetist so that he can plan what medication he's going to use for his hypotensive anesthesia and whether you need to twiddle anything before. Making sure that they understand that they have stopped their blood thinners is probably very, very important. As far as topical decongestion and infiltration is concerned, I think if the senior you get, it's easier because your junior has done it, but most important thing is just wait for it to act properly, no matter what are you doing. Positioning is important. You don't want to squeeze the veins and increase the pressure. If you have the head up a little, that helps a lot. Anesthesia, as I've said, that controlling your using beta blockers or whatever they use.
Any specific instruction to your anesthetist?
Yeah, I would like to have a hypotensive anesthesia if possible.
Okay, so dry field is very important, and for the anesthesia in our day-to-day practice, this is also very important, because as a face surgeon we should give some input to our anesthetist, because they used to actually start GTN for lowering the blood pressure, but ultimately that will increase the pulse rate and may cause the diffuse bleeding. So it is always better to use beta blocker in the previous night, and at the time of operation also esmolol or other beta blocker drugs can be used to reduce the blood pressure, so that the pulse rate are on lower side. So 100/60 is good enough with 60 to 70 pulse rate. So all these points are important for proper visualization and making the operative field dry. Yeah, sure.
Hello.
Yeah.
One point I would like to mention here is in the topical decongestant. This is what Satish Jain does in almost every case. If you realize, he spends 15-20 minutes, maybe 25 minutes, just painting the nasal cavity with small pieces of Merocel dipped in 1 and 2 lakh of solution. And he paints the lateral wall for almost 20-25 minutes. Yeah, I have also picked up from him. So it improves the surgical field. It gives easy access to your scope, and there is definitely good decongestion that happens.
Okay. Now I will ask this question to Dr. Deepak Haldipur. See, in any medical colleges, or when the young face surgeons, they are starting doing this operation, and we have a mindset that middle metal antrostomy is the easiest one, and we should start doing middle metal antrostomy, and if we can muster it, then we can proceed further. So what is your comment and difficulties during middle metal antrostomy in your day-to-day practice, and what would be your ideal size of middle metal antrostomy?
Hello.
See, when a postgraduate starts nasal surgery, the first biggest myth is we all think septoplasty is a simple surgery. And 10 years later, you realize a good septoplasty is an extremely difficult surgery. When we begin, we are very scared of the sphenoid sinus and posterior ethmoids. But you realize later, as you get experience, it is the maxillary sinus which is the difficult surgery. Because all these are in the sagittal plane, they are in the midline. You go straight. This is one which you go lateral. The biggest mortalities in ENT have been during adenoidectomy and tonsillectomy, if I talk about deaths. Similarly, the maximum collateral damage happens with the maxillary sinus in FES. We had a fair bit of people in the beginning who lost their vision when people tried to do middle metal antrostomy. So I think the beginners should not take it lightly, number one. Number two, I have 5 debriders in my unit, 5 debriders. But I tell the beginners, the first 100 surgeries, if you can stay away from the debrider, use manual instruments, get the tactile sensation, then you use the debrider. Especially when you're doing a middle metal antrostomy, it is better for you to palpate, use the Nagashima backbiter, go in there, hug the upper border of the inferior turbinate, and go ahead. If you are in doubt, go a little posterior into the posterior fontanelle. Please don't take middle metal antrostomy lightly. And if you are a beginner, don't be tempted to start it with a shaver or a debrider.
Okay, so take-home message is that all the points in phase are important. We should not take anything for granted, because in the very close vicinity and in the very close surroundings, we are having all those important structures. Dr. Komalendu Haldar, what is your opinion regarding the ideal size of middle metal antrostomy?
Normally, the middle metal antrostomy, the size is the normal 8 millimeter to 1 centimeter. But there is a 4 categories of the middle metal antrostomy. When you can actually, in cases of chronic rhinosinusitis, this case is only the grade 1. This is the normal middle metal antrostomy. But in cases of the extensive disease or polyposis, that cases middle meatal enterostomy extending to the posterior fontanelle. And this one is the grade 2, and type 3, when the middle meatal enterostomy is the extending behind at the floor of the maxillary ostium. This is the type 3, and the type 4 is that cases when medial maxillectomy cases, or whole of the maxillectomy in cases of the extensive either tumors or the inverted papilloma, or in cases of extensive polyposis cases that.
So this is another very important point, and lots of debates are going on regarding the size of this enterostomy. Some prefer very large enterostomy in all the cases, some prefer small enterostomy in all the cases. But I think the practical thing is that if we are dealing with fungal sinusitis, then we should go for a very large enterostomy, so that postoperatively we can clear all those sinuses, all those irrigation and everything. And if we are having the other polypoid disease, then we can have the moderate size of enterostomy, because according to some school of thought, the nitric oxide is also very important in the maxillary sinus for proper functioning of the mucociliary clearance. If we are having very large enterostomy, then the amount of nitric oxide in the sinuses will be reduced, ultimately leads to delayed healing. So a practical sense of approach, I think, is needed. So this is, yes sir.
Yes. Both to the panelists and the whole, I think everybody would agree, the uncinate process, without removing the uncinate process, completely unsatisfactory, metal anastomy would be half done out, 1/4 done job.
Okay, thank you sir.
Yes.
Now madam, how can you remove the polypoid mucosa from the extremely anterior part of the maxillary sinus? Because sometimes it is very difficult to remove those polyps from the anterior or anterior-inferior part of the maxillary sinus.
Yeah. For the last question, one more answer.
Yeah.
See, it is not the size of the maxillary sinus ostium which is important. It is how you preserve the mucosa surrounding it so that it doesn't go for stenosis, one. And second one is, as you said, in chronic rhinosinusitis, yes, that nitrous oxide what we need. So your ostium can be less than 1 centimeter, that's more than enough. Whereas with polyposis and all those syndromes what we have, we need to have a huge opening. That's there. Wall of the sinus ostium till the terminate in polyposis, so that whenever we do douching, it should go properly there, because the mucociliary clearance doesn't happen there. So that part I take care.
And how can you remove the polypoidal mucosa from the extremely anterior part?
Yeah, this is the most difficult. I try to use the angle scope. I usually have 70 degree and 110 degree, and then we try to see and then we remove, and then even the angled microdebrider also, and then Woozier, that forceps is the maxillary forceps, that also I use. If at all I'm not happy, or we can have another approach is pre-lacrimal approach also, we can go for that. But if I'm not happy, I still have some disease, not for the polyps. Polyps I can clear, but in other conditions, then I go for the canine fossa approach.
Okay.
So beforehand only I'll take, if at all those, the consent I take, but not for the polyposis, usually I can clear with these techniques.
Okay, so this is very important take-home message. We have surgeon satisfaction and we have also patient satisfaction, but at the time of difficult situation, we should keep aside our surgical ego. Then we can actually proceed through this canine approach to remove all the disease, because ultimately it is better for the patient purpose. And now this is for Dr. A.B. Bosch. What will be the surgical protocol for headache with isolated sphenoidal disease?
I think it's a tricky situation. Depends what sort of sphenoidal disease it is. If there is evidence that there might be fungus in it, I would go ahead and operate on it. If it is not, I would do an endoscopy, try and put decongestants and see if with that it opens up or not. if in spite of medical treatment it persists, I would do a spinotomy.
Okay, any comment from anyone in
No,
this
I will
regard?
agree.
Okay. So, this is for Dr. Arjun Dasgupta. When is the anterior ethmoidal artery most likely to get injured in your day-to-day practice?
As Dr. Holdipur was saying, that the maxillary sinus is one of the most difficult sinus as you start getting older. Because that's in a different plane. And while during the ethmoidectomy and you are trying to get rid of the frontal recess, you have to be very careful, and you don't injure it for quite some time. You go on getting away with one surgery after another, and then suddenly one day it happens. And that's when you really have to keep your guards down and your feet on the ground and think that this thing can happen. This CSF leak while doing the isolated sphenoid sinus diseases and the anterior ethmoidal artery injury can happen at any time. And you should know how to manage them if it happens.
So anatomy, and the reading of CT scan is of utmost importance. This is for Dr. Kaushal Shet. Does stability of the middle turbinate affect the outcome of face? Does medialization of middle turbinate help the outcome? And would you mind removing the unstable middle turbinate at the end of your surgery?
So I'll answer all three together. Stability, yes, it does affect the outcome of face, because if it's an unstable middle turbinate, you will have a lot of synec formation, adhesion formation. The pathway for the medical management, the intranasal corticosteroid sprays and all will be affected. So you can have a recurrence of the disease. Medialization of turbinate does help certain times, because if it's a very flappy middle turbinate, then probably I'll take a stitch to the septum just to improve the ventilation path. And unstable, I wouldn't remove a complete middle turbinate. I would partially trim it right a little below the axilla, so that the landmarks are intact in case there needs to be a revision phase, probably by another surgeon, if the patient doesn't come back to me. I'm being practical.
Okay, so even after completion of your surgery, good surgery, if after 1 month this will be the scenario, then all our good work will be in vain. So we need this type of scenario after the operation. Dr. Komalendu Haldar, as we all know, he is the master of face here in this place for last 15 to 20 years. He told me 10-15 years back that this thing is very important. We should try our level best to medialize the middle turbinate, and we should try to stabilize the axilla, because if at the time of mobilization, if there is fracture here, so there is every chance of lateralization of the middle turbinate. This is for Dr. Deepak Haldipur. Does frontal sinusitis always requires frontal recess exploration? And these are the causes of failure of frontal sinus surgery: retained frontal recess cell, retained uncinate, lateralized middle turbinate, neoosteogenesis, inflammatory mucosal thickening, and recurrent polyposis. So what is your take-home message regarding the frontal sinus surgery?
See, the frontal sinus drainage area, or what you call as the frontonasal duct area, which is an imaginary area, actually is nothing called a frontonasal duct. But that area, or the frontal recess area, your approach has to be just the way you would approach a eustachian tube area in the middle ear. The mucosa should be left intact, uninjured. It's the same analogy that you do in a thyroid surgery for recurrent laryngeal nerve. If you dissect around it well, the nerve will appear by itself. Similarly, you clear all the cells around the frontal recess. It becomes open. And if you are a good conservative fist surgeon, 99% of the cases you don't require to think of doing a draft, Lothrop and all that, because these are radical procedures. And remember, the moment you put your drill on the frontal beak, you are risking a huge neoosteogenesis. You should know how to do a draft, but that doesn't mean you do it left, right and center. So I would be very conservative in and around the frontal sinus area. Having said that, when there is a neoosteogenesis, or where I am convinced that that opening is lesser than 9 millimeters, likely to stenose, then yes, definitely you go all out. but that percentage of cases are very less. You're telling something, I think you're right. Sorry. My voice always is grade 1 sulcus vocalis and diagnosed by Jai Kumar Menon, so we can't dispute it.
Okay. So, this is for Dr. Kamalendu Aldar. What is your postoperative protocol? Because all the parts are very important for phase, preoperative preparation, operation and postoperative care for the better surgical outcome, cleaning, antibiotics, nasal douching, nasal steroid, oral steroid, follow-ups. Dr. Kamalendu Haldar.
The post-operative care is the most important thing for the management. Otherwise, if it is there is a loophole and there is a recurrence. And the first thing in the first date, they go for the antibiotics, oral antibiotics, and also after removal of the nasal pack, the cleansing with the normal saline, and along with there is a topical steroid like a budesonide solution, the resipules, and oral steroid for few days, for 5 to 7 to 10 days, but in cases of there is a allergic condition, there is along with allergic, there you can use the other antihistaminics and nasal dosing. But in cases of the severe the polyposis, that the oral steroid may be at least for the 2 to 3 weeks in the tapering dose, and others just to follow up the patient for the after 7 days, and then and there is a routinely there is a just suction cleaning and to debridement all the crusting of all the sinuses from the first week of the second weeks, and then after the 3 weeks interval, and for the monthly for 6 months, then you can 3 months for the 6 months, and then for the 12-month interval.
Okay, that means the post-operative care is also very important, and many centers, many doctors, they are having different protocols, but ultimately all these options are available, and we should try our level best to convince our patients to come for the post-operative care so that they are having better surgical outcome. So the final words is do as little as possible, but as much as necessary. So I have to run through this panel hurriedly, otherwise we are having masters in this field, but all our members are waiting to grill their presidents in the general body meeting. So I had to rush through this session, and finally I just want to share this information. Though we are having gala dinner in Stadel, and all our guest faculties will be available there, but Dr. Deepak Haldipur and Dr. Bharti ma'am will leave us tomorrow early morning. So ma'am, a final word in the conclusion of the scientific session from your end.
The session is on chronic sinusitis, sir.
We ENT people suffer from poverty of philosophy. We poverty because we think segmentally, but it is everything in the part of the body. Chronic sinusitis anywhere in the body is not, symptoms may be localized, but it has got a whole body participation. Our attitude to frontal sinusitis, the any sinusitis area, is still today very localized, which was valid only for the acute inflammatory state. But when it is chronic, I think, as for example, frontal sinus, I think for all practical purpose, of course, biology can never be 100% like mathematics, but it can be up to 97%. There cannot be, in most cases of frontal sinusitis, without other part of the, at least anterior group of sinus affected in that region. So our spectrum has to be much wider and never more. Otherwise, you become a very successful commando surgeon, but you lose the battle.
Thank you, sir. We are eagerly waiting for your session tomorrow. So, madam, final words in the conclusion of scientific program.
With respect to the teachers over here and my dear friends, the scientific session will never conclude. It goes on and on. So we'll be here next year also, Dwapan. So anyhow, because tomorrow morning we are leaving, I enjoyed the academics. Morning only I told both seniors and the youngsters are there. And really, we are very happy to see so many seniors here who have participated academically and who are the path, they lead the path for the youngsters. The youngsters should learn from them. And they are the members of the AOI, so they should support and make the AOI grow. And everyone should look upon our association. Thank you. I had a good time with you. Thank you.
Dr. Deepak Haldipur, sir, a final words from your side.
1980 August, Bharti madam and me were in the same anatomy dissection hall, first MBBS. She was always the first bencher, I was always the last bencher. And last
That is because of the height, that's all.
And last 42 years I've been trying to catch up and I am still the last bencher. But frankly, coming to Kolkata is a fantastic experience. Sometimes you do feel low, like now you have to go out of the general body where all the action is. And me and Bharti are not a part of it. Kya kare? But otherwise, I think every time I come here, the discussions are good, panels like this are good, and I like the energy Majumdar sir shows. But Majumdar sir, one apology is there was no poverty of ideas, it was pure poverty of time, which led to poverty of ideas, and Dwaipan had to cut it short. Thank you very much. If God willing, next year again, if Dwaipan feels I am not a useless fellow, he'll call me again, I'll come back here. Thank you.
Okay. So with this, we can conclude this session. And Snehashish?
I request Dwaipan Mukherjee to hand over memento and certificate to Dr. Anandapoto Bose. Dr. Kamalendu Haldar. Dr. M.B. Bharti. Dr. Deepak Haldipur. Dr. Kaushal Seth. Dr. Arjun Dasgupta. I request Dr. M.B. Bharti to hand over the certificate to Dr. Dwaipan Mukherjee. Now we'll start our GB meeting, general body meeting, and I request that all the members only stay in this hall, and those who are not members or become member after 3rd January 2021, please go out of the hall. And our dinner is at Stadel from 7 p.m. to 10 p.m. Live members. Only live members. Only live members stay in the hall. আমি আমার গাড়িতে আছে আমি ও মেরা গাড়ি
I'll go. Thanks.
I request Dr. Haradhan Bora, Dr. Subhajit Banerjee to come on the dais.